8:01. So we would like to be punctual. Good evening, everybody. Today we are going to discuss the issues related to long-term survivors. Uh, Long-term survivors, those people who are surviving with HIV, with treatment or without treatment, for more than 2 decades or so. Possibly for the same reason, we have chosen the panelists, which are also long-term survivors in the field of HIV. They have been all working for 2 decades, 3 decades, 3.5 decades, and that's the reason that your experiences are very important for those who are going to attend this webinar. These are very hard times. In COVID times, we are able to do only virtual meetings. We are not able to do any personal meetings or physical meetings. So let us discuss all those issues which are chalked out. On behalf of AIDS Society of India and Hetero Healthcare, I welcome you all. And I would like to share first the. Can I share from here? 1 minute. Get a permission to share. Share the screen. Okay. So file. 1 minute. Very difficult. Dropbox. Oh, 1 minute. Uh, 1 minute. 1 minute. 1 minute. Are you able to see this slide? No.
No.
Anyways, I will just read out. We are going to discuss the issues related to long-term survivors. In that, we have chalked out almost 10 subtopics. The first one being the AIDS survivor syndrome or ASS syndrome. Second one is physical health concerns. Third one is HIV treatment challenges and need to change regimen. Fourth is treatment fatigue and tolerability. Fifth is inflammation. Sixth is accelerated aging. Seventh is comorbidities. Eighth is quality of life concerns. Ninth is financial consideration and unexpected long-term planning. And last is mental health issue. Some of the issues are intermingled because, say, when you talk about mental health issue, there are issues related to other things which will be in a part of that. If you're talking about inflammation, accelerated aging is part of that. However, what we have done is we have 5 panelists: Dr. DG Saple, uh, Dr. N. Kumaraswamy from Chennai, Dr. Milind Bhushundi from Nagpur, Dr. Manjunath Dinakar from Hyderabad, and Dr. Divakar Tejaswi from Patna. So almost all geographical regions, east, west, south, north, we have people, and each of them will be speaking on 2 topics allocated to them. They will speak for 10 minutes, and then the other 4 panelists will have their intervention on those 2 topics for 1 or 2 minutes each. So total 10 minutes, next 4 of them, and then we can have question answer. So each 2 topic will have question answer, finish over there, and then we'll go to next 2 topics. So 10 topics will be divided into 5 panelists and 5 time slots. Accordingly, we'll take the question. Can I have first speaker, who is Dr. Saple? Uh, 1 minute, if I can get his slide from here. 1 minute. Can you see this slide now? Is this seen?
We can see the sharing. It has not yet come, but it showed that Dr. Ishwar Gilada has started screen sharing, but slide has yet to come.
Oh. Difficult thing, huh? Anyway, I will introduce Dr. Saple. Dr. Saple is a fellow of Johns Hopkins University, Bloomberg, USA. He's a former honorary professor and head of dermatology and venereology department at Grand Medical College and JJ Hospital, Mumbai. Involved in clinical management research and training programs on HIV/AIDS for last 30 years. Published many international papers and delivered more than 1,000 lectures in India and abroad. He's a ex-president of the IADVL, which is a National Association of Dermatologists, Venereologists, and Leprologists. 2017 awarded with the Lifetime Achievement Award by IMA Mumbai. 2018, he was awarded with Lifetime Achievement Award by IIDVL Maharashtra. 2019, awarded Best Practitioner by National and International Conference of Dermatologists. And 2020, he was felicitated for IIDVL Fellowship Program, Dermacon, Pune. Dr. Saple is going to speak on two topics allocated to him: AIDS survivor syndrome and treatment, fatigue, and tolerability. What we are going to expect from him is what are the cases of AIDS survivor syndrome, how they were managed, any specific choice of medication in these patients, how does a family or social support makes a difference, and so many other issues. So now it is there. Okay. So Dr. Saple, please.
Yeah, yeah. See, I do not have slides, so I'll just go without slides. Can you hear me? Am I
Yeah.
audible?
Yes,
Yeah.
sir.
So there are two problems. One is the survival syndrome, AIDS survival syndrome, and yeah, so when you're talking about AIDS survival syndrome, these are the psychological changes patient go through his HIV life or HIV pandemic. These are very brutal changes, and these psychological changes they occurs because of this sustained psychological trauma. They get continuous psychological trauma. They have compared with as if you're coming back from the horrible war and still you're battling the war because there were hardly any treatment before 96. So it was like a hanging sword. The death sentence was like a hanging sword, and the people were not sure how long they will survive, how they'll survive. So they used to go to a lot of psychological changes, and these psychological changes are various changes like depression, anger, anxiety, nightmare, insomnia, getting involved in the self abuse, isolation, go away from the society, many things, and many times they are not able to take even the right decision. So a lot of psychological changes used to occur because they divided this HIV into two: before heart era, and after heart. The heart is before 96. There was hardly any treatment was available because the treatment was not available. What I mean, antiretroviral treatment was not available. People were not sure how they long they will survive, what will happen to them, what will happen to the family. So there are a lot of psychological problem, and because of that, they were under depression all the time. I've seen, for example, one of the patient before 96 that they said, "Sir, we don't want to survive, and there is no treatment. What will happen to my life?" They keep on phoning almost every day because there's a cycle of trauma. So these people, only solution that they get support from their families, their relatives, their colleagues, their friends, society, and the supports from the government, then they become stable. So that is the only thing can help them. Nothing else can help them. But after 96, what we call is a post-heart therapy, the scenario is changed. The people now know there is a treatment, they can survive. But initially, there are a lot of side effects of the drug. I remember some of the patients used to give ritonavir 12 to 18 capsules per day. They used to get a lot of gastritis. They used to say, "Doctor, we don't mind dying, but we don't want to take this tablet." So they have gone through very horrible life. Then 2000, the nelpinavir came. With that, the side effects were less. And of course, now we have got only single tablet regimen. Single tablet regimens, and they can survive for long. So the whole thing is changing over the last 30 years. So now what is called is a AIDS survival syndrome. The psychology is changing, and it's changing for the good, because now all patients come, as with our experience, most of us we have got experience, they can survive long without much problem like Like one of the study they have mentioned that in before 96, they used to survive for 8 years on an average. Then 96 to 98, they used to survive for 10 years. Then after that, in 2002 to 2002 to 2004, the survival rate went 46. And now they say survival rate with a good quality of life is almost 60 years. So that psychological syndrome is now is almost all disappearing. Then talking about the fatigue, actually the when you talk about the fatigue, everybody feel this mental fatigue. Even to my mind it came, we are talking about the mental fatigue, but the ideally the word should be pill fatigue, regimen fatigue, or the treatment fatigue. This treatment fatigue is because of they go through again same thing psychological changes because they have to continue treatment for lifelong. When they have to continue treatment for lifelong, they get a shock lifelong. That's how that is the initial reaction. And they lose some of the patient, almost I know almost 10% of the patient, they lose their desire, their motivation to continue treatment, to maintain their adherence. And if you do not maintain their adherence, what we call they land up into non-adherence, they may land up into clinical failure or resistance, and they fall in the resistance again. The number of tablets they have taken some more. So again, that's complicated more. And even they do not follow even salvation therapy to what is nowadays called is MDR HIV, where the number of tablets are very high. So this is a circle where the consequences first is because psychological, second is non-adherence, then the resistance. So these are the people they land up into fatigue. The first because of lifelong therapy, in spite of telling them, but usually now because of this single regimen therapy, the whole thing is again changed. Like AIDS survival syndrome, here also the chances of fatigue is now less because they have to take one tablet. There are hardly any side effects. And even there is a comorbidity with the tablets. And now we have got a tablet with the less drug-drug interaction. So usually this fatigue was common before pre-heart era. Now it has not remained that common. And secondly, the most important part of the population is young people. Usually those people who acquired HIV during their perinatal age, they are the people at the age of 13, they become adolescent. Many of them, they are not aware of their HIV. When they become aware of HIV, they have to take treatment. Why they should? They have a lot of issues. So in adolescent, those are the people where the question of non-adherence comes and where they fall in this fatigue. There are there are very few studies how to prevent these fatigues. And one of the study which has been there, that only intervention is the treatment interruption. I remember treatment interruption was one of the suggestion long back because patient used to get fed up of the medicine. But when you have treatment interruption, they again go into low CD4 count, they get opportunic infection, and they again they become sick, and that add. So treatment interruption is not a good option, but this was one of the option was suggested for. But ultimately, this is being a chronic disease. What they need is the first support from their family, from relatives, from the colleagues, and financial supports from the government. And most important, they have to study that if they get good health care provider, their doctor, the doctor-patient relation is very essential. If they get a good HIV consultant, the meaning of HIV consult, the doctor who is managing large numbers of HIV patients for a long time, because then he knows what are the patient's problem initially, after 5 years, after 10 years, 15 years, because that doctors understand better than doctors who are handling very few cases per year. So if the patient get access to one of the dedicated HIV clinicians like all of us, I'm sure they'll have this less problem. I think now, Dr. Gilada, can you open for the question or you'd like to go for the next one? Hello.
Dr. Kilada, please unmute.
Okay. Can we have some interventions from Kumar for 2 minutes on these two topics?
So you want me to talk about the topic given to me, or you want to discuss this?
Not topic. What Dr. Saple spoke. If you have any interventions on that.
Yeah, I think he narrated I think from his own personal experience itself with managing patients for more than 25 years on what his patients went through, which we all have seen. We started with patients with no ART, just managing only the opportunistic infections. Then we had used monotherapy, 2-drug therapy, then triple therapy with a lot of bad drugs, difficult drugs like Intinavir and Sakinavir, which ritonavir we have used, and with multiple pills. I still remember those years. My patients used to have, 15 pills in the morning, or 5 or 6 in the afternoon, and again another 10 to 12 in the night. They all went through that. All those fatigue and side effects and the whole body shape changes and the cost. I still remember our patients used to pay around 30,000 rupees per month, for these triple drugs. It's all our patients went through all those, and still they survived. All those, so much fatigue and everything. I think during the course of my presentation next, I'll be covering some of those, how those challenges now, how we can overcome with the current strategies and the medications.
Dr. Dinakar?
Yeah, I think all of us had our share of, I would say, triumphs, interspersed, peppered with a lot of tragedies, both in terms of medical success, failure, family support, as Dr. Saple very nicely emphasized, is extremely important, particularly in the early days, and it continues to be so. And during the course of my talk, I will also share the problems of comorbidities. In fact, there was one editorial which talked about complexities of success. So because of success of ART, people are living longer, and now we are facing with the new set of problems, and which is again challenging but far easier to overcome than the problems of all the pill burden, side effects, and intolerability of the first generation ART. So I think it's been a success story if you really look at the entire trajectory of the HIV pandemic over the last 3 decades.
Very good. Milind.
Yeah. As usual, Dr. Sapre, your experience is tremendous, and what you speak is your experience. What you said of the same thing, I think I will also be covering, because most of the thing will be common as far as the mental health is concerned, considering this ASS syndrome. That is a very important. I just wanted to tell you one thing. I had a first prick, that is a post-exposure prophylaxis, which I have taken. That time I have taken 5 tablets of hard gel, saquinavir capsule, so I know how difficult it is, because I have taken just for 28 days. But can just imagine how many people have taken those 19 tablets a day and like that. So really, hats off to all the pre as well as post heart era, the survivors, long-term survivors.
Dr. Divakar?
Yeah, thank you, Saple sir, for the excellent presentation about the first cohort and pre-heart era and how difficult it was. And you have rightly question about how to prevent the fatigue, and one of the most important things which now all the HIV/AIDS patient wants to know, when we are going to get rid of these tablets, when is cure coming up. So cure agenda function has to be there, because your fatigue, prevention of fatigue, you have rightly told that intervention, treatment interruption is not the answer. And yes, indeed, doctor-patient relationship is the most crucial linkages in the things to come, in the betterment of the patient. And in few studies, which I will also discuss, in which pre-heart era patients are still continuing, and they have cited three reasons. And number one reason was doctor-patient relationship, which has motivated them to continue with the treatment. And the outcome is that out of those pre-heart era, out of 104 who are surviving, 97% are having viral load less than 50. So it is very important, the two things that you have pointed out. And thank you very much for your presentation.
I think these are the times we need to tell our young HIV practitioners and new patients coming that you are really fortunate. You have not seen the worst of the times. Sometimes when there were 2 or 3 infections in the family and ART was so expensive, the patients used to come and say, "Doctor, you please decide which one of us should take treatment." And it was so difficult for us to choose. Like the lady will say that my husband is a breadwinner. If he dies, all of us will be finished. Husband will say, I got HIV by my own deeds, but I given to my wife. I can't see her dying. And then they have a child and she is pregnant. So were very difficult times. I also remember that even to fetch 1 or 2 HIV medicines, that time only Cipla used to have. They had a condition that a doctor should accompany a patient to get the medicine from their godown. So each time we needed medicine, the doctor would go there, because the patient will be said, you write all your name, address, etc. before going. And the doctor would, before we interview a doctor, we used to tell him that you will need to go to that company with that patient. And then most of the doctors would say, no, I will not do that. That is somebody's pune's job. So it was so difficult. The Crixie one, Indy one, black market here used to cost 22,500 per month, only one medicine. And then you needed to add 2 more medicine. So it was very expensive. And what happened, I always sometimes blame the company. They cost so much that the moment some cost escalation is there because of newer medicals, they said, no, no, sir, we used to take this medicine at this cost. Now it is going 500 rupees more. But during those times, if they spend 30,000 per month, that is more than 1 lakh per 1.5 lakh now, because the cost of that 30,000 is 1 lakh now. So those were very difficult times, and people survived. Those who survived, they really are enjoying the best of the life now. But the doctors who are in practice, they think that it's not so much so difficult. But those difficult days were there that time. So now let us have Dr. Kumar. Dr. Kumaraswamy, may I share this slide? Are you able to see the slide?
It is still sharing. It has not yet come on the screen.
Can somebody from organizer share this?
Ishwar, should I start my slides? Okay.
Okay.
Yeah.
Kumar is
it has come.
of India. He's the chief and director of the VHS Infection Disease Medical Center. Currently also managing COVID patients there. He's director and site leader of the Chennai, that is CART, clinical research site, and located at VHS. Kumar is going to speak on 2 topics.
So,
okay, Kumar is going to speak on HIV treatment challenges and inflammation. And Kumar, please go ahead.
yeah. Hi, everyone. Good evening, and thank you for joining in the midst of this pandemic. I hope you're all staying safe and working towards preventing and managing COVID. So thank you again for this opportunity to speak to you, today evening. So what I'm going to walk you through is maybe in the next 10 minutes or something. I'm going to quickly show some slides and set the pace for our panelists to discuss. So I'm going to share my slides, and hopefully you're able to see this. Ishwar, can you say you're able to see this?
Yeah, we can.
Okay.
Yeah.
I'm sure you all know that this is the one we are all been practicing in our clinics. Someone comes to you, so you're going to start with a TLD as a preferred therapy. Even as Dr. Saple said earlier, even they would have been exposed to any other medications and still they are on first line if they're suppressed. I'm sure you would have moved them into this first line therapy with the TLD. So it's so easy, just one drug once daily. And you don't need to, you can take any time. It's unlike the previous medications. And also we have these alternate drugs like the efavirenz 400, where if you don't have DTG, and also the earlier regimen with 600 with efavirenz is not now gone out of the shelf. Also in the newer guidance, TAF is coming into this special population. And again, when patients fail this therapy, we do also have a second line with NRTIs, preferably either we recycle tenofovir or probably we switch them to other NRTIs and a boosted PI. And again, when they fail, we have a third line therapy. So today, our patients live longer, either with the first line, if they take it well, maybe 10 years, 15 years, they continue to take this. Even if they fail, we have powerful second line drugs available with this another 10 to 15 years. And again, if the patient have access to the third line, again, we have very nice drugs, very powerful. And also we do have less toxic drugs. So with this, our HIV infected person, if you start therapy, they can live for 30 to 40 years, without developing any major complications related to HIV disease. I want to single out here without HIV disease. While doing so, they also go through several other issues, which I'm going to show you, and we can have a discussion, with the panelists, how we're going to start it. When these patients, go with this medication over a period of time, they get aged, and we all know that the kidney function decline. Also, tenofovir is a mainstay drug either for first line or second line in our patients over a period of time, which also can cause declining kidney functions. As shown by our own data many years back, almost 5.6% of the patients when on long-term tenofovir can develop renal dysfunction. And also, similar observations we've seen by other cohorts in other Asian countries. To solve this, we do have this novel drug TAF, which you all know about this. You can see in this cartoon. For a tenofovir to act, you need to have a larger chunk of drugs to be given at 300 milligrams, where majority of them get excreted to the renal tubular function, causing more damage to the kidneys. Very small quantities going to the target sites. Coming to the TAF, you just need a very smaller quantity of 25 milligram. Most of this drug goes to the target site, very little get excreted, thereby we can reduce these toxicities. This has also been shown very clearly in several clinical trials. Just for one of time, I'm going to show just one study showing that, as shown in the orange color curve, where it says patients who are on tenofovir containing therapy, they have high proteinuria and albuminuria. And as shown in the purple color, where patients have declining proteinuria and albuminuria and being switched to TAF containing therapy from the tenofovir when they are at baseline. So this very clearly shows us tenofovir on a long run is toxic to the kidneys, and also when patients live longer, they also will have a declining kidney functions, and this all will add to that. Also, when patients live longer, they all go through the osteoporotic changes and several metabolic complications, including many bone abnormalities. Also, we all know that tenofovir can cause this. Again, if you look into these particular graphs, where you can see these DEXA scans done both as a spine and as well as a hip. We see this, and patients who are on with tenofovir, as shown by orange color, where they have a deeper bone mineral density loss, both at the spine and as well as the hip level. But when they are being changed to TAF from tenofovir, it improves both at the spine and the hip. So that means, when they live longer, the aging itself is causing a lot of bone abnormalities, and with the tenofovir, what we are using as the mainstay drugs also causes this. Now TAF can rescue this. Having said all these good things about this, again, what these patients go through on a long run. I'm sure we all see this in our clinics. We all feel that it is due to the integrase inhibitor. Dolutegravir preferably we have been using, but also other integrase inhibitors also have shown, as shown by the cohort from Europe and as well as from the US. We do not have much data from other integrase inhibitors other than DTG from resource limited studies. So at this time, is it only the integrase inhibitor causing this weight gain, but is this a combination of other drugs? Very clearly, this data has been presented a couple of months back at the virtual CRY, and now it's been published from a very large clinical trial conducted in Johannesburg in South Africa, a study called ADVANCE study, where they compared 3 different arm groups. One group received tenofovir, emtricitabine, and efavirenz. It was compared against tenofovir, emtricitabine, and DTG versus TAF, FTC, and dolutegravir. It's quite a large number of patients, 1,053, almost 300 in each arm. And in this study, in a snapshot, they showed higher weight gain, particularly among South African women when they're on a combination with the TAF, FTC, and DTG, which you can very clearly see in this particular line graph. If you see the panel, which is on the left side, is for the men, where you can see this blue color one is the one patients who are on TAF-containing therapy, and the red one is on tenofovir with the DTG, and the other one is on efavirenz with tenofovir. We see clearly shows that TAF produces more weight gain, along it's been given along with the TAF, dolutegravir, as compared to tenofovir and dolutegravir. Again, if you see on the right panel, which is on the women cohort, where the patients have seen with higher weight gain with the TAF and dolutegravir, almost 10 kilograms over a period of 96 weeks. And again, when they live longer with these medications, this obesity can cause further issues. Again, having said this, have you seen in our Indian cohort? I'm sure all you clinicians have seen this. This is the data from our own Chennai cohort. We showed a year back. And again, I just wanted to show that, we have seen this with the tenofovir at that time, not with the TAF at that time. We didn't have that. Now we have a TAF also, where we have seen at the 6th month and 12th month with the weight gain, but didn't further showed insignificant subsequently. And also when we switch from TLE combination to TLD, we have seen at the 6th month, but that significant didn't achieve over a period of time. Hence, it is just dolutegravir alone, or it's a combination of TAF with dolutegravir as shown in the in the advanced study, which further we need some studies from our own setting, particularly from India, where obesity itself is a major factor in at least 20 to 30% of our Indian population. Having said this, can we drop this tenofovir, which is producing so much of toxicities, especially when people live longer, when they have a declining kidney function as well as with the bone toxicities? Yes. This drug, which is now approved by US FDA, called Devato, is a combination of 3D and dolutegravir, and someone who is already being suppressed with the standard 3 drugs. And if they are suppressed, you can definitely change them. Thereby, we can protect them from their declining kidney functions and bone toxicities. But on the other hand, cannot be given in hepatitis B co-infected, and also as well as in TB patients. Also, there is another 2-drug combination without tenofovir or TAF drug called Juluca, which is a combination of dolutegravir and rilpivirine. And just for your information, again, rilpivirine is an NNRTI, which cannot be given if they have an NNRTI baseline resistance. And again, this can be given in virologically suppressed people. But the good thing is, if they have any moderate to severe renal dysfunction or osteoporotic change with CVD risk, this can be a good drug, because tenofovir can further cause more damage to declining kidney functions. And again, someone who being longer, now we have a lot of options, where we start with one particular drug with triple combination. When they suppress and if they have other risk factors to produce other aging-related disorders, you can change them to other medications. Again, having said that, our previous presenter, Dr. Sople, very clearly talked about the fatigue, where patients are totally fed up with everyday taking these drugs. To solve this, now we have these long-acting injectables coming up. Cabotegravir, which is again an analog of dolutegravir, which is being developed as a long-acting injectable, which with a half-life up to 40 days. Also the rilpivirine, which is an NNRTI, but is also being developed as a long-acting injectable with up to almost 3 months with a half-life. Now both together is being tested already in LATE-2 trial. Week 40 data is already been published, and 96 been just presented at the virtual CRY, which very clearly shows that even if you give every 8 weeks, it has been non-inferior as compared to oral therapy. In fact, excellent satisfaction among patients who are taken this. That means someone who is fed up and fatigued with the everyday oral therapy, they're already been suppressed with oral drugs, this can be another option to rescue them. It's been well supported by 2 other very good studies, again, been presented and published very recently, called Atlas and Flare. So that means our patients, when they live longer, we have other options to rescue them to prevent these long-term toxicities, as well as from various everyday oral fatigue and other things. Again, having said this, today, for caring our people on long-term is not just with one possible option. We need to have multiple baskets. We need to reduce their reactive drug exposures by reducing the dosage, where we have options available, reducing the number of pills, And also there are a lot of new investigational drugs available. Don't sit tightly with one drug. If they have other comorbidities, whenever new drugs coming up, move them. If they are being with efavirenz on a lung run, move them to bictegravir. Now it's been currently available as TAF FTC, and bictegravir as a single pill, or as a TAF 3DC and FTC and dolutegravir as a single pill. Move them. Don't keep them with the same old drugs. Also, we have got a lot of other newer formulations like long-acting coming up. I think we, as a clinicians, we need to look at as options for our patients who are on long-term on ERT, so that we can prevent the toxicities, as well as also prevent further complications related to aging process, as well as the fatigue-related these oral medications. This is again my first part of the talk, and second part is going to be very brief on inflammation, where someone who is HIV, which we all know that the virus goes up. Along with that, you can see all those pro-inflammatory cytokines, which I'm sure you may be hearing every day today from media and as well as from scientific talks with the COVID, where all those cytokine storm happens, which also happens in HIV during the acute process. You look into the interleukin-6, TNF-alpha, IP-10, all those have been upregulated, which causes profound inflammation, which you're seeing in COVID, as well as we saw that in HIV in the past, as well as now also. So we saw that in the acute phase of HIV, but it never went down even in the chronic phase. Continuously, these fires happen, causing more inflammation and causing more and more non-communicable diseases, which you'll hear more from my other colleagues later. What are those non-communicable complications, which I won't go into the details, but it'll be talked later soon. But why these are being caused? All because of the inflammation. Why? Because of the cartoon which is showed, HIV induces inflammation, both at the acute phase as well as in the chronic phase. Also the co-infections like tuberculosis and other comorbidities induces, and also the microbial translocation and obesity. All those pushes these inflammatory markers, causing more and more comorbidities. So inflammation plays a huge role, even when you put them on the best drugs, single drugs, and the better drugs, this will continue to produce all these complications. Then you may ask a question, whether the antiretroviral drugs, what we use, whether it reduces these inflammations. So our group and others have really been shown that by giving these antiretroviral drugs, you'll have a modest decline in inflammatory markers. It may not be a level that suppress all those to prevent these non-communicable complications. So that means ERT alone is not enough. You need other supportive drugs. To show this, we have been now conducting a very large clinical trial called REPRIEVE in 100 different sites. So this has been funded by US NIH, where our Chennai site is one of those larger recruiter on patients who are already on antiretroviral drugs. We're using a statin, particularly with the pitavastatin against placebo, to see whether it suppresses inflammation to prevent various non-communicable diseases. This is a work in progress. So probably this could be another standard of care along with antiretroviral drugs to prevent these long-term complications when someone is on antiretroviral drug for many, many years, like 10 years or 15 years or 20 years or so. So I'm going to stop by to the show to the panelists, since we are now in the COVID era. So what is our long-term patients? Today my patients ask me, I've been taking antiretroviral drug for the last 20 years. I've been living so healthily, I'm fine. Now I've been very much worried, with this COVID. So will I get affected? I've been keep hearing a lot, comorbidities will cause a lot. Will this common with HIV, will living longer with these wonderful medications, whether they will get battered with this COVID disease. To talk about this, very little data currently been available, very few case reports. There are 4 or 5 case reports been published in the literature on HIV and COVID. And again, I have reviewed some from our Asian cohort. I'm sure you all have seen patients in your clinic, but from these published, from our cohorts, almost only just 12 patients from our Asian cohort with HIV and COVID. I'm sure it might be more in your clinic, which has not been documented, and please document all those findings. Again, so no one knows it is because I feel probably not enough testing had been done among HIV infected people. Right time to test some so that we'll have some idea whether HIV itself will be a protective factor or they acquire COVID just like any other persons. There are a lot of speculations who have been speculated already, where defective cellular immunity, which is already seen in HIV, whether it could be paradoxically be a protective factor, no one knows. Unless you test all your cohort of thousands and thousands of HIV infected people who don't have COVID, probably we can speculate there is something behind them. Or one of those antiretroviral drugs, they take them. Initially, we thought protease inhibitors, we never know that, whether it is due to tenofovir. Again, studies show that it's not been protective. So this is something what we need to study as clinicians and document whether this COVID really affects our patients or they have been protected for some mechanism. We don't have data at this time. So again, just I'm going to wind my presentation to open for the panelists to discuss that what advice we'll give it to our patients who live longer on antiretroviral drugs for 10 years and 20 years, along with your social message which you are given. Make sure that they strictly adhere to antiretroviral drugs and OA medications. Very important. At this time, don't change the current effective non-PA based regimen. For example, they are on TLD or TAF-FTC, bictegravir. Don't change them to a PA based therapy, which some of the clinicians are doing and asking me questions. Don't do that. We don't have any data to show that the protease inhibitors can protect you against COVID or treats COVID. There is data shows from lopinavir has not been effective as a single drug. So at this time, don't change from your effective non-PA based therapy. And also make sure that they also adhere to the medications for comorbidities with diabetes and hypertension, which you all hearing the data that our COVID patients are becoming sicker and getting into your ICUs if they are comorbid other conditions. Same thing can apply to your HIV infected persons. If they have other comorbid conditions, if they're not having controlled diabetes, if they acquire COVID, then probably they may end up in a similar scenario. So this is something, a good piece of advice you need to give in the current scenario to a patient when they live longer with your wonderful antiretroviral drugs. With these piece of advice, we need to give it to them. I'm going to stop and throw upon to our panelists to ask me questions or discuss on this. Thank you again.
Thanks, Kumar. Should we have intervention from Dr. Saple?
Yeah. See, I entirely agree with the Kumar. He has covered most of the things. Only I would like to add something about the COVID. The COVID, there is a very good study from the Spain. They have followed 3,000 patients of HIV, and it was quite surprising result. The number of HIV patients getting, am I audible?
Yes.
Yeah.
It's okay? It's okay? Am
Yes,
I
yes.
audible?
Yes.
Yeah. So they have followed 3,000 patients of HIV. It was surprising result that the number of HIV patients getting COVID were less compared to non-HIV. Number two, if HIV patient gets COVID-19, then their symptoms were mild or moderate. Hardly anybody had severe symptoms. Their recovery was fast. And even my personal experience, my 7 patients of HIV, they had COVID, but they had mild symptoms. They never need any admission. All they were confirmed with the real-time RT-PCR. So this is about the COVID, and as Kumar has already said, probably defective immunity, which is preventive cytokine storm. That is the possibility.
So Dr. Saple, I agree with you. When you said that you got a lot of patients in your cohort of HIV, I think it's worth to document. Even in Wuhan, I'm been in touch with the clinicians who are taking care of large number of COVID patients. They have very few HIV. In fact, in the largest hospital in Beijing, Ditang Hospital, where they treat large number of HIV infected people, they have not seen even one HIV patient with COVID, even in China. So I think if we have a large series in Mumbai, so I think it's worth to document that, because nobody else has been seeing this type of large number of patients, especially in HIV. So I think it's very important to document them. And also, as you rightly said, it's been clearly documented from other cohorts. Whatever they have seen, the symptoms are very mild in HIV. But on the other hand, if they have other comorbid conditions like diabetes and hypertension, then the complication could be similar like a non-HIV patient.
Yes, correct. That's right.
Okay, can we have inputs from Dr. Dinakar?
Yeah, I think this is really a very intriguing kind of observation, and it's been uniform across the world to why there is a relative protection for HIV patients on treatment, irrespective of what class of drugs they are on. And this is something really an area of research I think we may have, because paradoxically there's already an inflammation in a cytokine storm going on. So theoretically they should have been more vulnerable. But on the other hand, there is some kind of a protection going on of the existing cytokine storm, or what is really an area of intense research. I think really helps us to get more into the molecular biology of COVID itself by studying HIV patients. In fact, in our cohort of patients, we are following more than about 1,000 patients. And nobody, and a couple of them mild symptoms, but they're all so scared to go and get themselves tested, self-limiting course, and they all sort of recovered. Clinically, they were obviously strongly suspected to have COVID, but unfortunately could not be documented because of barriers in testing.
Dr. Milind Bushundi.
Yeah, wonderful presentation as usual, Kumar. Two quick points. TAF emtricitabine efavirenz 400 versus TAF emtricitabine DTG. What you will prefer?
So this is something, efavirenz 400, which we all know that, we had spoken in so many forums together. We have debated too, in the last, 2 minutes. So now, we with great difficulty, we have moved out of NNRTA, which you know that rising NNRTA resistance, many Africans sitting more than 10%. In India, almost 10%. We don't have good data, but it could be anything from 7 to 10%. So if you don't do any baseline resistant testing, it might be very difficult to use this efavirenz 400. So I won't compare just like this. We have gone to a different era from NNRTA to integrase inhibitor era. So again, I won't go back. And again, I won't couple with a very good drug. TAF such a wonderful drug as compared to tenofovir. I won't compare that with a drug like efavirenz where we do not know whether it will work or not. And again, efavirenz 400, ENCODE data showed in such a way that it is non-inferior. But there will be little, the CNS disturbance. It has not been well powered for that. So I won't say that even in our clinic, sometimes when we put patients on efavirenz 400, they still develop some dizziness, could be much lesser as compared to efavirenz 600. So to your question, I won't do that. I will still go with TAF FTC DTG, but on the other hand, or TAF FTC with the bictegravir, which is also been now available as a single pill, as a TAFIC, which you all know. But on the other hand, with this weight gain from advance, probably I may document, I will do a lot of other lifestyle modifications on these patients. Do them exercise, change their food habits. So, today I feel that it might be a combination of multiple factors, not just alone, the drugs alone. So I think I will do that. So in case, if they still continue to be very obese, probably I may drop TAF first, but still I'll keep an integrase inhibitor along with that because that has been much more potent and closely monitored now. So, but on the other hand, the patients who are already on your efavirenz 400 with a TLE 400, will you change them to TAF? Probably yes. If they have a declining kidney function with the tenofovir, and if they are well suppressed with the efavirenz 400, if they don't have any side effects, probably I may remove these TAF, 3DC and put them on TAF FTC, tenofovir 3DC and put them on TAF FTC and combine them with the efavirenz 400. So this is something where probably you can use it, but I won't start anyone, on TAF FTC and efavirenz 400 at this time without doing baseline genotyping.
Another one is the DTG plus rilpivirine, viral load estimation before rilpivirine.
So, again, that Juluca, rilpivirine is now been approved by US FDA. And again, it has not been approved to initiate anyone on this treatment because you all know that rilpivirine cannot be given in somebody with a viral load of more than 100,000 copies. But those studies are done not with the dolutegravir. It's done with NRTIs, that is the tenofovir in FTC and the rilpivirine. Now, probably still it might work with the dolutegravir because it's such a potent drug. But still, I won't recommend today to our patients to start this with. We'll start with a TLD, make sure that they go on undetectable viral load. Then you drop tenofovir and put them on, dolutegravir and rilpivirine. Or someone who is already on TLE with a 600 or 400, if you're on suppressed, that might be a perfect patient because they have already been exposed to NNRTA. You know that they don't have mutations. They are well suppressed. So still rilpivirine will work very well. So that might be a very good candidate to put on dolutegravir and rilpivirine and as a Juluca, especially people who are on TLE for 10 years or 15 years on them. Someone who is on TLD or on TAF FTC and bictegravir, if you change them to dolutegravir and rilpivirine, you may have to do a viral loads more frequently at the beginning because you may not know that whether they have baseline NRT resistance. But if they're viral load, if you keep doing every third month, it's separate, then that's fine. I think this type of strategies we need to develop in our patients who are on long-term therapy. But definitely DTG and rilpivirine, will become like a standard of care, especially in patients whom we cannot give TAF or TDF on a long run. And again, this has currently been available. I'm sure our Indian generic companies are already in the process of manufacturing. It might be very cheaper. Rilpivirine, which you all know that we are doing these studies, Melinda, you have been doing with us. It has been less toxic, and we don't see any major adverse events, so it could be a very good drug.
And I totally agree with what you said regarding the COVID. I had 25 SARI and non-SARI around 15 of them. Not a single of these patients had any COVID positive. But my problem was when I had a patient of a PCP pneumonia, which was unequal. The ground glass appearance on the HRCT was very different than the usual. Then I was worried. So the COVID was negative. What is your advice? Should we repeat the COVID again in such patients?
Again, you know that, right? When you say the ground glass appearance, they are symptomatic. So that means they are not in the window period, right? They would have been gone into that. So RT-PCR should pick them up. But again, now data coming up that, the sensitivity is very specific. RT-PCR to SARS-CoV-2 RNA is very, very, very specific. But on the other hand, there are data shows that it could be only around anything around 80 to 90%. Some people are saying 75%, we don't have good data. It could be anything from 80 to 90% sensitive. Still 10% it can miss. It's not because of the window period, because your patient is already having ground glass appearance. That means they're gone out of the window period, but because of the sensitivity issues. So probably today I tell all my clinicians in our hospital, either they are taking HIV or diabetic or neurocare, everyone take precaution and take proper PPE. The minute when they say talk about PPE, it's not just like a COVID full PPE. Use a N95 mask, use a face shield, wear a gloves and goggles, and is something what protect. Very careful while you have been examining a patient. Make sure that they don't cough on you. Keep your face away. While you're having a conversation, don't direct your nose and mouth towards their mouth. Is something what we need to learn now. From our patient. Of course, this should be practiced in the context of HIV, especially with TB and with MDR TB. But now COVID is really teaching us a lesson that we need to stick to this basic. But on the other hand, should we assume it was a COVID? We do not know. I think probably I may, if you still suspicion that they are not doing well, I may repeat another RT-PCR to see whether another test is picking up. But again, mostly 90% should pick up if they are really COVID positive.
Yeah, thank you.
Quickly, Devakar, any inputs you have?
Very nice presentation, Kumar Swami. Just I wanted to know that when are we expecting 3TC and dolutegravir if coming in India?
I don't own any companies, so I'm not manufacturing. So what I heard is now, since it's US FDA approved, so Indian companies have been interested. They have been talking to us. I think, that they will start manufacturing only if the resource limited setting guidelines start recommending, because they need some evidence that we will be using them. So today, it's been part of the DHSS guidelines, the European guidelines, and British guidelines. So our WHO guidelines is seriously looking into that. So in fact, we planned a guidelines meeting. If we planned a meeting last week in Geneva, and because of this COVID, that meeting got postponed now to September. It's unlikely going to happen. So these were some of the things that we plan to discuss in what type of population we can use this 3DC DTG. So I think based on when the recommendations come in some of the guidelines, Indian companies will quickly manufacture. Because it's not easy, difficult for them. They already have lamivudine. They already have dolutegravir, and now they have this formulation from an international innovator. So to compare this and get this certification is much easier. Also, I was told by one particular generics, they're already been working on dolutegravir and rilpivirine. So probably that might even come into the Indian market, and it might be very cheap.
Thank you, Kumar, for a wonderful presentation.
Thank you.
We are running little bit late. I request speakers to be precise in time. And what we'll do is we'll take questions at the end because I've seen the
Yeah,
list of coming. The questions are also on the presentations, which are going to be in, after some
yeah.
time. So, and there are kind of questions which are intermingled here and there. So we'll have questions from the audience at the end. So, may I request now the third speaker, uh, Dr. Milind Bhushundi. Milind.
Yeah.
Milind is MBBS MD from Government Medical College, Nagpur. He is Arthur Ashe Fellowship, Department of Infectious Diseases, Well Cornell Medical School, New York, USA. Also, certificate of HIV medicine from University of South Florida, Tampa, USA. Invited TRG member at NACO. Official Goodwill Ambassador in HIV/AIDS, invited by US Department of State, USA. Presented 10 papers in international AIDS conferences and 4 papers at IS conferences. One original paper in Science and included 2 meta-analyses in Lancet. Ex-professor at Jawaharlal Nehru Medical College, Wardha, associated with Sarthi. He is the director of Central India Institute of Infectious Diseases and Research and medical director and chief HIV unit at Lata Mangeshkar Hospital, Nagpur. Uh, he is going to speak on financial considerations and unexpected long-term planning and mental health issues. Dr. Milind, please.
Thank you very much, Dr. Grada. Can I have the next slide, please? Yeah. So thanks Hetero, basically for inviting all of us. And today is the day we all know that the 5th June is the day of the HIV long-term survivors. And basically it is for the awareness and those people who are fighting and still fighting these HIV epidemic. Next, please. So as Dr. Sapra has already told us, we had long-term survivors, HIV and aging, or aging HIV. So all these three terminologies are totally different. If you talk of pre-heart, Dr. Sapre has already told you what we used to see during that time, that the patient used to come with the opportunistic infection, again with the infection, again with the infection, and ultimately used to die. And that was what exactly the people during that time in the pre-heart area had. They just had the early adulthood has gone in the just believing that they would die young anytime and watching the scores of their friend die. As far as the post-heart LTS people are considered, they are much better. Those who have completed 10 to 20 years. But I'm also important group which I wanted to tell you is HIV negative LTS. The another group of the long-term survivors that tends to left out of most of the conversations, and those are the HIV negative partners. We have to look at them, the way they have supported. I remember a lady who the patient is still alive. He came to me in 1996, and that lady left everything in the house because this particular fellow was moving from various postings from here and there, and just neglecting her family. She was with him all the way only for the good adherence. So these people are the champions, and these companions and caretakers are really the champions of and one of the very key role in long-term survivors. And yes, definitely, we all of us, we are also the HIV negative LTS. Next, please. So we all know that HIV, the age is increasing. The the various studies are there. Next, please. Next, please. Hello, 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 hello. Can you just forward the screen, please? Next slide, please. So we next, please. Yeah. So recently, Pradeep Kumar from NACO, he has published his own modeling, where in India also the mean age is going to be from 38.4 years to in 2005 to 45.5 years in 2025, and the proportion of the HIV infected people aged 50 years and older increasing from 19% in 2005 to 37% in 2025. So we are going to see definitely various different patients with non-AIDS comorbidities and increased treatment complexity, as well as the inevitable need for the multidisciplinary healthcare services, and definitely to ensure the high quality of the survival. Next, please.
थोड़ा सा एक और
Next, please. Yeah. So, do all LTS are old? As Dr. Sapa has already told you, that we are not only talking of the older adults living with HIV, but however, not all the HIV long-term survivors are older adults. The people now in their 20s and 30s who acquired HIV at birth, and we are very young, and they don't know really what has happened to them. And the mental, if you are talking of mental health issues, they are going to suffer much more than the other one. Then there are certain another group which is LTS partners without their partners in the age of group of 30 to 50 years. Next, please. So I'm coming to the mental health issues. I have divided, next please, basically into the ASS, which has this part has already been taken by Dr. Sapre. Next please. Uh, so I'm going to talk basically for the young LTS. Breaking the news to these young people is really a problem, all of us we know. And the post-disclosure psychological and emotional impact is tremendous. And why me? That is what they ask to everybody, including us. And I definitely know that many of these young LTS might have asked you, why me? And somehow, out of some of them definitely develop the hatred towards the parents, and the psychological aspects and the stress of growing up with HIV is tremendous, and than a normal population of their same age group. Children with HIV infections, they have to spend a lot of time in their hospitals with for self for the parents. They are being asked by their peers why they are going to the hospital so often. Why at the same time, this another chunk of their basically the HIV negative uh, brothers or sisters, the siblings, they are also facing this problem, that why only my brother who is HIV positive is look after more than me or by my parents. So that issue is also there. Then there's a mental issue like self-esteem, careless behaviors, possible high-risk behaviors, and the thing is, when the time will come, how they are going to disclose it, whether they have to disclose it or they don't have to disclose it. Nowadays, we are getting all the young chaps. They are indulging. They are definitely having the friends out of maybe some boyfriends or girlfriends. So what they are supposed to do in that group, they don't know. The commonness of the anxiety and depression. So there are n number of issues which are now being faced by these young LTS, and that is ultimately resulting to the high rates of depression and other mental health issues in these patients, as given in various studies. Next, please. The old LTS, the people living with HIV are twice likely to have depression compared to those who are non-infected with HIV. And I was how you can differentiate in old age whether he's having a senile dementia, whether he's having the effects of the drugs, that is the efavirenz, or really they are having depression. It is very difficult that itself, because that is the overlapping basically. So what Kumar has told us, that to change the medicine, like those who are having going to cause the neurocognitive problem, neuropsychiatric problems, to the drug like DTG, not DTG, because DTG may also have the same problem. So we have to do in certain manner that the drug regime should definitely the tackle the problem of mental health issues in old LTS. Already a significant concern for HIV positive older women is there because they are at more risk of developing depression, prevalent among the HIV LTS along with the other serious mental issues. Next, please. Next, please. So main is the isolation from the community and family. Somehow, as they are growing, they have gone up with their partners and friends, but ultimately they are facing the main problem, and that is the isolation from the community and family. There are numerous negative health effects because of this. That is including the high rates of death from the chronic health conditions. There are multiple losses, trauma, decreased ability to live home or get around it, some stress use, financial concerns, caregiving duties. So n number of health issues, mental health issues are there with this old LTS. Working with mental health providers, social support and sense of purpose of life are the key ways to decrease the isolation. And here comes the role of the healthcare providers. We have to talk to them because they don't have anybody to talk to them. So talk to them, talk to them, and talk to them. That is what we can do, and the same thing which we are doing in our own clinic. Next, please. So, what is the solution? So we are facing these three problems. So we are having a group तर काय झालं मराठीमध्ये तर काय झालं means मला काय झालं and it is in the same way Vinay Kulkarni's group so what so in that group we are having a group of young LTS those who are they have started their own group and because of they are supporting each other one of our young LTS has got admission in IIT as well as IIM. 6 of them has got in engineering colleges. One is MCOM with CS, and this is the success story. And though the number of young LTS in this Tarka Zala group is less, it is just 110 Tarka Zala young LTS. But definitely, they are having a role model that they can be definitely going in for good things with a good support from our side. There are three marriages, what of the young LTS, and when then definitely the baby is the baby is negative, so they are happy. So this is what we are doing in Tarka Jhala, and this group is definitely helping us. The second group is between the age group of 30 to 50 years. We are having one Sanjeevan Sanstha where we are having buddy concept. The buddy can be a friend who knows that the status of the because this Sanjeevan is basically the group. It is HIV positive. All the HIV positive are there. So that buddy thing is there, and they are supporting each other and that is a best part of support as well as emotional as well as psychological as well as social. They go on picnics, they go on to see a movies and every lot of functions are there, so they are themselves with the help of doctors and our uh, counselors, they are definitely doing a wonderful thing. Then major problem is about the LTS. They don't have any group. Social groups are not there for the old LTS, and only the here comes the role of the family members as well as the doctors, and the counselors. So those who are coming to us, one Kaka is there. That is, he is the first patient. That is from 1996. We call him Kaka because he is the person who is motivating the old LTS so that they don't have the mental issues. Next, please. Uh, we all know that HIV associated neurocognitive disorders. I will not go into that because of the short of the time, but this is not. We know that this one half of the patients have the same degree of neurocognitive. Next, please. Next, please. So, what are the risk factors and pathogenesis? So, definitely CD4 less than 200, as well as the advanced HIV, the age, illicit drugs, HCV co-infection, with the age, cerebrovascular disorder and sleep disorder, and definitely the psychiatric comorbidities. They are the main risk factors. And uh, as Kumar has already said, that the inflammation is one of the main, the neurotoxicity and the neurotoxicity of the drugs. Here comes the role of low-level HIV escape in CNS. You must have seen a patient in first line, no any evidence of uh, the neurocognitive functions. Patient goes on tenofovir, lamivudine, atazanavir, ritonavir, develops PML, develops some neurological problem, you see for the escape and you get it. So this is what the second line, which is from basically in the government setup, which they are developing. Next, please. Next, please. Next. Hey, next. Yeah. So what are the challenges? Next, please. Yeah. So the key take-home message is neurological decline in aging patients with HIV is multifactorial and relatively prevalent. The clinical manifestations of neurocognitive elements have changed in the combined ART era, and clinical management remains a challenge, and more research is needed. Next, please. The financial consideration and unexpected long-term planning. This is really a difficult topic because just to say that do financial considerations and prepare for, see, it is not for the HIV, it is for everybody. Next, please. So we also have to face this problem. So what we do in our clinic is a pre-ART financial counseling. Literally, my counselor, who is a pre-ART counselor, that is a pre-treatment counselor, she will look into the total financial aspects of that person as a individual, as well as the family liabilities, as well as whether he can continue the ART in the difficult situation. So before starting ART, we always discuss. The ART counselor, the pre-treatment ART counselor, discusses all these problems with them, and in consideration as regard to the job, occupation, whether he is a farmer. So these are all points which are taken. And always I say that the option of the government ART centers, we always give to each and every individual who we find that he may not sustain financially in future, as well as we try to see for the family financial support. Then we ask them to for the recurring deposits, microfinancing, as well as saving options. This 2+1 approach. This is a very unique approach in our clinic, where after the two visit, the person will be not be will be charged for the any investigation or any the consultation fees, as well as the investigation, including CD4 also, or one on one. That is मराठी मध्ये आम्ही म्हणतो बायको आणि नवरा बरोबर आला तर बायकोला ती नवरा free. That is, one person is given free consultation as well as all investigations whenever we find that there is a financial crunch. Linkage to the different government schemes, that is very important now, because a lot of schemes are coming from the government side, and linkages to the different government schemes may decrease their financial problems. And then we have to help them in retiring planning. So retirement planning is very important, and what we ask them is, like, if they are going to retire after 10 years, they should start saving for the money for the medicines after 10 years as or before 10 years. So that is what 1+1 scheme is there. So where they are already utilizing this in a big way. I don't have much of the idea because Mediclaim is the other thing, but recently there was a guidelines from uh, the NACO about the Mediclaim, but I don't think, or I don't know exactly whether there it is implemented or not. In life insurance policies also, there are a lot of issues, but fortunately now what has happened is, what I have seen is, they are only looking at the claims which are less than 3 years. If it is more than 3 years claim and the person is say positive, the deceased one, then they usually give the insurance. Next, please. So what Kumar was telling in the beginning regarding the financial aspect, he has very much nicely depicted in his article way back in 2007 December. And if you see that financial burden of the health services for people with HIV, it is tremendous. And the same thing, next please, uh, is by Monica, and she has also exactly what number of patients, like 540, and what they do. Extended family or friend take care of the children permanently, borrowing with the field. So all these things we already discussed with the patient before we start the ART. Next, please. And unexpected long-term planning, what is next? That is always the thing which in front of them. So talk to them when they are approaching, the long-term survivors are approaching to this old age. We have to tell them about the future. Then they don't should not get panicky. And we all know that there is a good campaign, kick ass, that is kick ASSS. So that is the campaign which is going on in US. We should have similar things. And as far as the retirement is concerned, we have to tell them it is not that what they are going to get. And we usually ask them to work with our own Sanjeevan, where we try to somehow uh, adjust them as far as the income generation schemes are concerned. Next, please.
Milind, please hurry up.
Yeah, this is the last one. Financial planning and unforeseen events are expected irrespective of the zero status. So plan for it. As a healthcare provider, help him in planning and considering the ART. Government ART centers are always good option rather than drug failure. Family, healthcare personnel, counselor, and the PLHRV has to participate in unexpected long-term planning. Thank you very much.
Thank you, Milind. Can we have very brief interventions and no questions? Questions, let us give that privilege to audience. If you have any additional inputs, please give. We'll start with Divakar. Any additional inputs, Divakar?
Thank you.
Okay, Dr. Saple. Unmute Saple. Saple, unmute.
Okay. Yeah.
Okay.
The most important things about the mental health come across my practice was the HIV phobia. HIV phobia was very difficult to manage compared to, because most of the thing Milind has covered. Talking about the financial, I remember one of the patients I'm following since 92, he used to come and ask me question, how long I'm going to survive? Can I work 14 hours in a day? So I said, what is the problem? So he said, we have three brothers. One looks after production, one of marketing, and I'm looking after licensing in Delhi. So any project comes, I have to get the all license done. So I must survive for 6 months for working for 14 hours. So these are the various problems of finance.
Kumar.
I think Milind brought all those important points. Coming to these mental health and neurocognitive, that itself is where you can give a lecture a day. So HIV itself can produce this, and as well as many drugs which are toxic to some of those neurons. So now there are a lot of studies have been currently happening how you can rescue these individuals by changing these medications. And also we know about this compartmentalization of this viral load. Someone who suppressed viral load in the plasma, still can be viremic in the CSF, which can cause some of those neurocognitive impairment and producing a lot of other different types of mental health. So that again, need to be assessed case by case. Some of them need just counseling. Some of them need some drug changes. Some of them combination of multiple factors. And also, thank you for talking about this financial planning, which we did a lot in our clinics many years back, where patients, when we started our triple therapy practice, where it used to cost around 25,000 rupees per month. We had to do a lot of financial counseling, on them. Even our richest patient couldn't afford on a long run. Then when the price started coming down, we spend less and less time in doing this financial, counseling. And today, with this TLD regimen, is at a throwaway price. In fact, it is a lot cheaper than even antibiotics and as well as diabetic medications and hypertensive medications. So those, when even I tell my patient, new patients, it costs this much, they said, only this much. So it's completely a change, from what we have done in the past till now. So I think we also have to keep changing this on those, on the, the long-term, financial planning on them. In fact, now financial planning is needed for everything. Now with COVID, we need to do a lot of acute financial planning for everybody. So this is something what we need to do, not just for HIV alone. So, but we have to do this, for everybody. But with HIV, thanks to those Indian generic manufacturers, we're able to do less and less financial planning on them because, it's, more affordable now. And also government is doing free programs. Thank you.
Dr. Dinakar, please.
Yeah, I think I will echo what Dr. Kumaraswamy and of course Dr. Wat Milind talked about. I think we should not forget the contribution of the Indian generic companies to make the financial burden to the patients less and less. And single treatment regimens, TLD, TLE, etc., whatever. I mean, as Kumar rightly pointed out, they're actually quite surprised. People with diabetes, hypertension, there are several heart disease, etc., when they come, the cost of the ART is the least compared to cost of insulins and other things. So that is, but it doesn't draw us away from financial planning, because as all speakers have emphasized, the longer age group and also the projected lifespan being almost at par with any other general population. So financial planning will definitely be part of the treatment goals, but it's in a different perspective and on a different time scale.
Very good. I will now introduce the next speaker, who is Dr. Manju Dinakar. He is a PGI Chandigarh graduate, chief consultant physician, MD internal medicine, Sunshine. He works with Sunshine Hospital, Hyderabad. He is a PI in several HIV trials, field research in HIV and metabolic syndrome. Now pioneering in telemedicine and consultation for HIV patients. He is going to speak on two topics, which are comorbidities and quality of life concerns. I think both are interlinked with each other, so he is going to speak on those two issues. Dr. Dinakar, please.
Yeah. Thank you, Dr. Gillard, for the
you will think
introduction.
earlier speaker got good time, and you will not. Everybody will get time. I got permission from the organizers to extend this webinar by 15-20 minutes more, so don't worry. Go ahead.
Right. Thank you. Thank you, Dr. Gillada, for the kind introduction, and thank you, Hetero Group, for making this all happen in these difficult times. I know it is a little late in the night for the audience, but my previous speakers have made my job somewhat easy, so I'll be able to stick to my time, probably finish it much earlier. Yeah, I think all the speakers so far have emphasized the fact that our HIV patients are just not living longer, but they are also looking at quality of life. So we are no longer just talking about adding just life, adding just years to the life, but you're also talking about adding the life to the years. So under the circumstances, quite naturally, as one would expect, as patients enter the 4th decade, 5th decade, and in fact, as per CDC fact sheet, by the year 2030, 70% of our HIV patients will be above the age of 50 years. So we clearly need to be mindful of the comorbidities which we will all expect these patients to have. And one of the regions of interest being internal medicine by training, we started looking at metabolic syndrome almost 10 years earlier, and we're still looking at it. And although our study clearly showed there was a slight higher incidence of metabolic syndrome in our patients, HIV patients, compared to the general population. And then when we started looking at it and data, etc., there are two additional drivers why these people have a higher burden of metabolic syndrome, and that is clearly due to the chronic inflammation, which Kumar and others have already highlighted, and the immune dysregulation. We also need to keep in mind the metabolic syndrome, which is nothing but a clustering of fasting hyperglycemia, hypertriglyceridemia, low HDL, and abdominal obesity, as you can we all know about it. There are several social and economic determinants for driving this metabolic syndrome, and we all know the clustering of things like smoking, alcohol abuse, and poor family support, financial burden leading to dosage discontinuation, etc. So in addition to this, once we determine this patient has the diagnostic criteria for metabolic syndrome, I always tell the trainees and the junior staff, please emphasize lifestyle modification every visit. And it is so important, and we have also realized when we emphasize this on every visit, it works. You have to give them, suppose there's an abdominal obesity developing, or it's one of the INSTI related weight gain, we have to start the lifestyle modification process even before you actually start or change medications. So the general myth is, patients with HIV lose weight, so I have to eat a lot, and then I make sure that I'm actually gaining weight. So we have to change that mindset of most of our patients, particularly the people who have been survivors, and tell them that weight gain has to be metabolically healthy. So obviously we are talking about reduction of abdominal obesity, or the so-called, which translates into visceral obesity, and again contributing to the inflammation. Now, having said that, we all know that metabolic syndrome is important from public health point of view because it is known to clearly increase the risk for cardiovascular disease and stroke by threefold compared to the general population who do not have metabolic syndrome. So how do we address this? So we have this so-called Framingham risk score for cardiac disease. So we put all the usual things, diabetes, hypertension, lipids, etc. But when we do only the Framingham risk scoring for our HIV patients, clearly studies have shown, including the DAD registry, etc., that we tend to underestimate the risk. So the DAD has come up with its own risk equation, which takes into consideration the CD4 count, whether the patient is on abacavir treatment. As we all know that abacavir actually increases the risk for myocardial infarction. So when you and the viral load, so you factor in all this, and then you realize the risk for cardiovascular disease in these patients is higher than what you will estimate using the conventional Framingham equation or any other pooled cohort equations. So when you do this, Kumar already did mention about the adverse effects of certain class of drugs, particularly protease inhibitors on lipids. So when we choose, obviously we don't unnecessarily move the patients out of protease inhibitors unless they're having undesirable side effects. So we are always looking for protease inhibitors which does not produce the problem of hyperbilirubinemia like atazanavir. Then we said lopinavir is all producing too much of dystrophies. Then darunavir came. So we are all very happy. Now we are also single pill 800 by 100. But then we also data is clearly showing that darunavir boosted treatment also causes increased risk for cardiovascular morbidities. So then that has given us the opportunity to shift to integrase inhibitors. There is a problem of weight gain, but integrase inhibitors as a group by themselves do provide some kind of a cardiac protection. So when the patient comes to us, it is like a Dhoni standing behind the wicket and doing the field placement right. So you don't get your field placement right, you leak boundaries to the opposition. So you may get your ART very right. The viral load is undetectable, CD4 is healthy. Then tell, okay, you take this same medicine, come back after 3 months. But you have not paid attention to his metabolic syndrome. His triglycerides are flying at 500, for example. So we need to keep cognizant of all these things. So basic screening, all it involves is doing a fasting sugar and lipid profile. And now the latest guidelines also say that even non-fasting lipid profile is validated. So we don't have to make the patient come back again to your clinics. So simple waist measurement, BMI, and also just do this sugars and lipid status, and seriously consider them on putting them on statins. Now, when you're talking about statins and with so many comorbidities clustering together, all of us who are practicing physicians should be mindful of certain important drug-drug interactions. For example, the one important drug interaction with statin is simvastatin should not be used when you're using protease inhibitors because it increases the levels, etc. So that we can't carry it in the head, but there are simple websites where you can go and check whether these interactions are red flagged or not. Anyway, having said that, the statin of choice in these patients is supposed to be pitavastatin, which though not very freely available, but we can use atorvastatin, rosuvastatin with caution. So how often do you need this? Definitely at baseline, and whenever you are making any change in your regimens, that's the time when you really have to screen these patients. And I already emphasized that we need to emphasize the lifestyle modification every visit, and also involve the family members. Today it's not, you don't have to go to a swanky gym, but at least you can ask him to reduce his carbohydrate in the diet, exercise becomes a part of his daily routine and so on. So that is important. Whether there is a role for a primary prevention with statins, Dr. Kumar already talked about that so-called reprieve trial, the results of which is awaited. So we may be probably entering an era where we are putting, like how we used to put Bactrim DS upfront for most of our patients, we may be putting statins upfront for some of our patients, especially those who have crossed 40 or 50 with other comorbidities and risk for cardiovascular disease. So that is as far as the cardiovascular morbidity is concerned. Kumar already made my job easy by considering the renal part. See, now what also happens is majority of the practitioners are happy just doing creatinine without looking at the EGFR. So it's important to look at EGFR because the tenofovir toxicity before it comes in, the creatinine doesn't get abnormal very early in the course of the usage of tenofovir. One of the simple things you can do is just do a urine dipstick for glucose. So if you get a normoglycemic glycosuria, it's a red flag. You are probably dealing with the probable tenofovir-induced toxicity, and now we have the choice of changing to TAF with no difference in the cost. So renal monitoring is not so difficult, but we also need to remember that in these kind of hot summer months, they are prone for prerenal azotemia and ATN. People also go and use a lot of native treatment, so that also can contribute to renal comorbidities. Also remember that when you use a combination of TDF with atazanavir, they have a sort of cumulative effect on the risk for nephrotoxicity. So these are all things which need to be. So renal is not very difficult to screen. The another hidden danger, as far as again this was covered by Kumar, but again like to emphasize about bone toxicity. Predominantly, we are looking at osteoporosis. So just not enough to patient is complaining of back pain. You just do a chest X-ray, not sufficient. Majority of these patients, especially when they have other risk factors like postmenopausal women, family history of fragility fractures, those who have been on long-term tenofovir treatment, they should be advised to get a DEXA scan. It is a little expensive, but DEXA scan is something which will pick up the presence or progression of bone mineral density to osteopenia or osteoporosis. In fact, there are certain elegant studies in these high-risk group of patients, particularly postmenopausal women. Of course, we can make the change from TDF to TAF. They can be put on annual injection of zoledronic acid, which, as you know, is a bisphosphonate and can help in the because somebody has a fragility fracture at say 55, 60, because you use this treatment and HIV is contributing, you're unnecessarily contributing to loss of quality of life. And this is very much preventable. So that is the point we need to emphasize. So it is not only juggling the ART medication, which has now become easy as you see the current guidelines, one single drug you pick up, TLD you pick up, you're practically right in using it for almost every patient. But that is just one part of the story you're covering. You're dealing typically with the patient whose average age group is say 40 plus. You have to address the comorbidity factors and look at the patient as a whole. 30 years back, when you say examine this patient from head to foot, you are actually looking for opportunistic infections. Like, you know, look at the fundus for retinitis or oral candidiasis or herpes and genital ulcers. Today, when you are saying a head to foot examination for a stable HIV patients, we are talking about screening these patients for comorbidities, keeping metabolic syndrome in mind, and also screen for metabolic bone toxicity, renal toxicity. And again, one more issue which again was highlighted is the presence of neurocognitive dysfunction. Now, this can be again multifactorial, the neuroinflammation, compartmentalization, substance abuse, alcohol, etc. All of them can contribute, but they need to be screened. How is your memory? Oh, you're going for work? No, you will have to actually administer a proper mini mental scale examination or equivalent of that. Then you can pick up because people who have been working in top executive functions, now in their 5th decade of life, etc., they feel a little bit of slowing down, sort of accelerated slowing down compared to the rest of the population. So things like neurocognitive dysfunction also needs to be screened. So we are looking at multifaceted management of these patients on several systems. And this is, I think, should be part of the training for people who are part of the HIV treatment. I'm talking about the newer generation. It's not just about picking up some drugs of ART from the shelf and just writing and disposing of. You have to treat the patient as a whole. So that is, I think, my key message to the audience who have tuned in. Thank you for
very much brief and precise, and within 11 minutes you finish everything. So may we have some inputs from Divakar?
It was a very nice presentation, and indeed there are newer drugs which you have suggested, and we are also seeing many kidney problem with tenofovir, like in southern cohort that Kumar Swami was presenting. Here also around 6 to 8% we are seeing with tenofovir the kidney problem, and now newer drugs are there. So it is very good that you all have narrated that.
Kumar?
I think I agree with all Dr. Dinagar said. I think we have to look at the patient as a whole, not just on when to start and what to start and put them on ART and forget them, just doing only the CD4 and viral load. So as part of the routine practice now, as part of the guideline, even for developing country, so doing a blood glucose annually and a lipid profile annually, and checking their blood pressure and creatinine, it's very, very important as part of the routine care. If you don't do that, you may keep doing all those antiretroviral drugs, make sure that the virus is suppressed, but on the hand, we may put them in a dialysis center or in a acute coronary care center, with all those complications of cardiovascular. I think we have to look at the patient as a whole. And also, as I said in my presentation, this aging happens in HIV-infected people in a much earlier. So we have been seeing what is called accelerated aging. It could be due to the inflammatory process, due to this HIV and other co-infections. So I think we need to look at, in HIV-infected people, what the internists and other clinicians are looking at in people at 60 plus years. We need to look at much earlier, how we can prevent them, how we can diagnose them early so that they all can be managed, simultaneously. And very importantly, make sure that they take the right diet and exercise. And it's very important, to prevent the frailty syndrome, which is again another major event which we are seeing in HIV-infected people, when they're on ART on a long run. And again, we need to look at the patient, as Dr. Dinagar rightly said, as a whole, not just on ART alone.
Milind?
Yes, when Dinakar said that for the young doctors who are going to practice about HIV, writing a TLDI, a simple drug, that is what they think is HIV. It's not. You are absolutely right, Dr. Dinakar. It is really a complex thing, and now in future, it is going to be more complex. Though the regimes are they are becoming very small and single tablet, but at the same time, they are going to live longer. Polypharmacy is going to be the major factor, and that is what you exactly said. A nice presentation.
Dr. Saple?
Yeah, see, we always learn from the patient. When you follow this patient for long term, you keep on learning from them. So I remember one of my patients that's about 10 years before, he said, "Doctor, do you know my all other friends, they're having, somebody has going undetected diabetes, they were suddenly detected, some have got myocardial infarct, some has got kidney problem, but I am an HIV patient, I do not have." So I said, how it is possible? So it is, sir, because every 6 months we come to your clinic, we get checkup done, not only for HIV, but for kidney, liver. So you said we are aware, our problems can be detected and can be taken. So, this is another things I learned. So all people, of course, now about 30, 35, all, not only HIV, but all other people, they have to be careful about their general health. So this is the things I've learned from my patient.
Thank you. Now we have our last presentation for today's evening. May I introduce Dr. Diwakar Tejasvi, who is going to Dr. Diwakar Tejasvi is MBBS gold medalist, FCCP, MCH, and PhD. Is a medical director at Public Health Awareness and Healthful Approach for Living, that is PAHEL organization. Ex-medical director, Ratnai International Health Organization, USA. Ex-head health officer department, Alemaya University, Ethiopia. Is a member of the American Academy of Family Physicians, Australian Society for HIV Medicine. He was nominated for 2-3 awards. He received what awards he received was International Health Professional of the Year, Cambridge, Pride of the Nation, Buddha Peace Award, Lord Borden Powell National Award, Dr. Rajendra Prasad National Medical Martandya Award, Nai Disha Parivar Lifetime Achievement Award, and Hippocratic Award. He is going to speak on 2 remaining issues. One is aging, accelerated aging, and physical health concerns.
Yeah,
Dr.
thank you
Diwakar.
very much. Thank you very much, and thank you, Hetero, and for remembering the long-term survivals of HIV on this particular day. And before we start, I just want to acknowledge the oldest known person living with HIV was Miguel, the Lisbon patient who died last year at 100 years of age. And just as others have already discussed the holistically the overall approach, my task has become easier about the physical health concern of HIV, and those with research on older adults with HIV, the ROVE 2 study 2018, they have listed that what were the main concerns they reported. Main complaining concerns complaints was fatigue, neuropathy, arthritis, and chronic pain. And common the problem of aging faced by these were cardiovascular system because of stiffening of arteries, the problem of cardiac problem emerging from that, and bones, joints, arthritis, density, bone density becoming weak and leading to fractures, loss of muscle strength, and in digestive system there was constipation, altered digestive problem, bladder and urinary tract, there were prostate enlargement like in another population. And there were two issues: aging with HIV and HIV in age. So aging with HIV have a greater risk of delivering certain age-related illness like cardiovascular disease, we all know, kidney, liver, cancer. But HIV in aged, if diagnosed late in course of illness, late start of treatment, it possibly lead to more damage of the immune system, can lead to poor prognosis and shorter survival. And if it is detected late, if it is diagnosed early, also if it is detected in the old age and diagnosed early, treatment has different psychosocial effect, and polypharmacy in older adults are very important, as it was mentioned also. And how aging with HIV is different than aging without HIV. There were different studies which has pointed out that researchers over the past years have found that HIV positive people have higher rates of certain age-related diseases like CVD, some non-AIDS cancers, kidney disease, than people with same age without HIV. In the study, it was found that biological age was significantly greater than chronological age by means of 13.2 years in HIV positive compared to the same comparison group by mean of 5.5 years it was, and in non-blood donors with HIV negative counterpart, it was 7 years lower than the chronological age. That means that if HIV positive is there, even if it is suppressed, like Dr. Kumar Swami has already mentioned, it leads to low-grade inflammation and it leads to biological age more than the chronological age by 13.2. And when we differentiated how it counted in that particular study, it was said that saquinavir was given and it added to 1.2 mean years. CD4 less than 200 was adding mean of 3 years. Hepatitis B co-infection, another inflammation causing agent, added 7.4 years, and cytomegalovirus CMV added 1.9 years. So altogether, these low inflammatory processes, even though suppressed viral load, it leads to more than 13.2 biological years more than the chronological years compared to non-HIV. And how does the regular exercise, yoga, and recreation helps? We try to see that, and it was found that significant increase in weight, lean body mass, and the sum of chest, arm, and thigh circumferences among those who are engaged in regular exercises. And we have seen also that almost 4 kg of grip strength is seen for every decade, losing of 4 kg of grip strength every decade for people age 50 and more. So that means if we extrapolate that, 2 kg of wasting is estimated to be having effect of 5 additional years of aging. So this muscle mass loss is prevented by regular exercise and yoga and recreation, and that helps in conserving the things. The effects of addiction we also tried to see in HIV infected older age population. Addictions affected in two ways. First, in acquisition of HIV is more prone those who are addicted, like in cigarette. Different studies have shown that smoking, drugs, alcohol has more chances of acquisition of HIV, and in progressing of HIV also, if there is addiction, it is seen that it progresses there. And in Alberta study, the Canada study, which has a larger cohort of from 1980s to 1996, and then second 1996 to 2013, out of these 20 years, there were altogether 876 patients prior to 1996 registered, and 104 were in constant continuous care in 2016. 97% had less than 50% viral load, because one important thing was that they were adherent, and there was no addiction among most of those who are continuing with the treatment. So effects of addiction is also known to cause some basic problems. At the same time, second topic that I had been given was accelerated aging. How it is accelerated aging? Is aging accelerated, or is HIV causing accentuated problem of aging? It is increased exposure to the comorbidities due to which acceleration is there, or accentuation aging process. What are there the different things between accelerated aging and accentuated? See, in other words, does HIV accelerate aging through pathways and mechanisms common of aging processes, or is HIV simply an additional risk factor like other risk factors for a wide number of chronic conditions? Then accentuating aging means accelerating aging is progressive, accentuating aging is just one time, just additional risk factor. And it was seen that chronological versus biological ways, when HIV is entering the body, it is causing low-grade inflammation, and throughout inflammatory processes, it is causing accelerated aging. And the accelerated aging, we have seen that in other types of infection, viral infection, if it is co-infected with HIV, it accelerates the aging process. Like previous study has shown that cytomegalovirus and hepatitis B virus, it accelerated aging much faster compared to aging alone. So HIV was associated with accelerated aging, and different organs also were affected by HIV, and like we have seen, cardiovascular, renal, liver, neurocognitive effect, brain cells, they are directly affected by the HIV virus. And at the same time, the virus which is causing immunomodulation or immunogenicity, it is also causing the double impact of that, and it is also causing accelerated aging. So HIV infected individuals are an increased risk of age-related non-AIDS morbidity and mortality compared with HIV uninfected persons. It is also speculated that HIV infected individuals may not be the aging chronological, but also undergoing accelerated biological aging, which we have seen in the last study, that 13.2 years more than chronological aging, mediated by increased cellular time and organ senescence. So these are the different studies which suggested that aging is there. But contrary to that, there was one Danish study which we all will be knowing, that they contradicted that this aging is not accelerated in well suppressed HIV infected persons. And Danish study raises this question about accelerated aging in HIV. And 6,000 people living with HIV/AIDS versus 53,000 matched HIV negative persons. And the study was conducted between 1995 to 2014, and they had seen the 9 serious age-related diseases like myocardial infarction, stroke, cancer, neurocognitive deficiencies, kidney, liver, and osteoporosis, and they have come to the conclusion that these are not significantly different between so virologically suppressed HIV persons and non-HIV infected persons. So this is one study which is contradicting that accelerated aging is the HIV is causing accelerated aging. And at the same time, the last topic which we wanted to compare the progeria model, like progeria accelerated aging is there. Can it be applied to HIV aging processes? Whether the two things are some kind of similarity or what? So there was one paper also on progeria model of aging and HIV accelerated aging, and but in that we have seen that progeria is a rare autosomal dominant genetic disorder, and it is caused by gene mutation in lamin A, impaired the ability of just mesenchymal stem cells to differentiate down the specific lineages. So it is not the pathway which through which the HIV aging is there. So this progeria model does not apply specifically in aging process of HIV, which we have seen. So in this regard, HIV definitely is a chronic manageable disease now, but the previous, prior to 1996 and after that also, with passing time, we are having lots of newer molecules which are having less and less side effects, and the longevity is now almost normal, and seeing into lots of holistically the patient's profile and patient's thing and doctor-patient's relationship. These all things can be controlled, and we have seen in practice also that those who are living in my practice also, more than 1,000 patients, out of them 50 to 60 years of age are around 146, and more than 60 years are 76 patients. So they all are doing well, and they all are mentally alert. And one thing is common in all the 50 plus patients also, which we have seen in our cohort, that before there was question that how long we will live during the start of treatment, but now they are asking for more quality of life and more of queries about having safe sexual health and like that. And when they are getting the information of U is equal to U, but have to take care, undetectable is untransmissible, they have come with a very positive sign, even patients 50 plus, and we are seeing that lots of changes are there in HIV treatment management, and we hope that with this type of day, long-term survivor of HIV, and this type of awareness program, this type of newer ideas, we will be able to manage HIV better in future. Thank you very much.
Thank you, Divakar. Let us have a few inputs. First with Milind. Quick inputs. Unmute yourself. Unmute. Yeah, unmute. Okay, good.
So fantastic presentation by Divakar. He is having a tremendous experience as far as holistic medicine as well as HIV both are concerned. One of 2 points, quick points was, is there any role of the HIV drugs, that is the heart, on the accelerated aging? That is my main question. And second is there any role of the inflammation, the chronic inflammation, what Kumar was describing in this accelerated aging?
Yeah, definitely. A very nice question. Definitely, the earlier heart, like which we are seeing, Secunavir, one study was done in which we have seen that chronological age, biological age was 13.2 years, mean age was higher than chronological age, And one point which added the mean year was Sakunavir dosing. And Sakunavir has led to 1.2 years of mean age of aging process, accelerated aging process. At the same time, now it is banned, but mitochondrial toxicity of stavudine, earlier it was thought that it is leading to aging, accelerated aging also. So those of the molecule, those not very good, and with experience and with more and more patients, we are seeing that as you have also mentioned, adverse effects, and they are getting out of the pool now. So these medicines also have some accelerated aging role. At the same time, a few medications which are good enough and later additions, their study and their long-term effects have yet to be seen. And yes, second part is chronic inflammation is one of the major reason for the aging. And from the virus entry, the body is trying to get rid of that, and they are by themselves in a inflamed conditions by fighting with immunological substances. And this virus itself is a kind of pro-inflammatory condition. At the same time, which immune system responses which we are generating, that is also causing sometimes for aging processes.
Dr. Dinakar?
Yeah, I think first of all, a very elegant presentation. There's no doubt the key drivers are basically the inflammation, the chronic low-grade inflammation, and the immune dysregulation, as all the previous speakers have emphasized. We have to really carefully look at what is the contribution of the newer class of drugs, particularly integration inhibitor. Does it really contribute to accelerated aging, like what some data has been used with, say, stavudine and drugs like saquinavir, which are no longer in use. So that will be interesting to look at. So again, we need to differentiate between chronological aging and biological aging. And when we are talking about biological aging, is there a death happening at the level of mitochondria, or is it actually the telomeres, which is supposed to determine longevity, telomeres present in the ends of the chromosomes, which may also be affected by chronic inflammation? These are areas worth looking at, because again, as we said, we are not just talking about chronic manageable disease, HIV, we are talking about quality of life. So aging is something we can't quantify. Oh, you're looking old, you're looking young. So it is, there is a little bit of subjectivity involved, but that plays on the psyche of the patient. So we need to be aware of this sensitivity about these things. What is there? You are anyway surviving. Why are you worried about your looks? We cannot say that anymore. In fact, several of my patients, drug-induced lipoatrophy and dystrophy, they have undergone plastic surgery because they want to look good. They want to get rid of the buffalo hump and this bull neck, etc. Very successfully. And they are all doing well, and they have a better self-esteem. And that is important at the end of the treatment. When they stand in front of the mirror going for work, they should have a good self-esteem of themselves. So aging is something which has to be addressed.
Dr. Saple?
Yeah, Divakar, it was a nice presentation. I think one of my patients, what I'm following, is surviving for 95 years. He joined me when he was age of 68. So almost last 25, 26 years with me, and he's doing very well. When you're talking about the aging, as the aging advances, the comorbidity also advances. And the comorbidity of HIV and non-HIV, for example, hypertension is almost same after certain age, but the kidney damage, cardiovascular comorbidity, diabetes, that increases more in HIV, even the bone, because the antiretroviral therapy, the bone damages is more. So these people, they because the aging, there is a comorbidity. As there is a comorbidity and the aging, the main thing in aging happen is the affected factors are absorption, metabolism, and excretion. And these patients are on polypharmacy or many drugs. And because of a lot of comorbidities involved, I would suggest, or usually in my practice, I involve multi-system management more than managing alone. If you take one of the renal specialists, cardiac specialists, diabetes specialists, we have better results.
Kumar.
Thank you again, Dr. Devakar, for your overview. I think this aging itself is it's a process which everybody goes through that, but we are seeing this in a very accelerated way in HIV. It's a complex factor. Now, coming to this, we have been discussing about some of those ART will help or not. So there are several studies have been done, and also there is a group, this North American Accord. So they keep doing these inflammatory markers in their patients over a period of time. They keep change. They would have started with ACT monotherapy, would have been intinavir, then subsequently with the TLE, their ARRR, and subsequently now on their TAF, FTC, and Bictegravir. So no reports have shown that ART really suppresses this inflammatory markers. They all have done. It's a very modest, but that really won't help. But what we are seeing, in our patients, leave alone HIV, even in the general public, we are seeing this accelerated aging. Not just on their looks alone, but if you look into their disease profile, people are all getting hypertension at 35-year-old, diabetes at 40 years, and many of those other age-old diseases. Now that means there's a complex factor. It's their own stress, the type of food, less rest, and their the way they have been living, and also a lot might be due to this pollution, which we have not been talking about, and the climate changes, which causes probably more and more this accelerated aging. So some of the factors can be controlled, many of them cannot be controlled. I think the carry-home message for the end clinicians is we'll be taking care of these HIV-infected patients, but HIV itself will be a major factor for accelerated aging and those diseases. And we should work with the patients how the other factors like their smoking, quit smoking, good rest, exercise, good food, and repeated counseling on them, should be imparted in every visit. Thereby we can make sure that they'll get away from those stress-related inflammation. I think all those really will help our patients live longer despite when we have these such wonderful antiretroviral drugs. Thank you again.
Thank you, Kumar. I think all of you have done wonderful job. This is not a physical conference where you could have seen you have done wonderful job, but audience is half empty. Here there are more than 400 people which are logged in, and all of them are still there. So in audience, we could have asked them to give a clap, but at least we can give a clap for you. You have done wonderful. Now we have some questions, and I ask all of you to be very precise because there should not be mini talk on answering the question. So let us start with questions. Does the therapeutic vaccine available, is the therapeutic vaccine getting available in near future, or people with HIV have no live with HIV with ART? They have to live with only ART. So Kumar, I think you can answer this. Is there going to be vaccine, or they have to live with ART only?
So,
Vaccine is we need to say therapeutic vaccine.
Yeah, the question on therapeutic vaccine, there are several trials had been done in the past which had failed. That is, people who have been on antiretroviral drugs, they're given, stop the drugs and given therapeutic vaccines where they have seen a rebound of HIV and causing more complications. Then the trials happen along with antiretroviral drugs who got been suppressed, then giving the therapeutic vaccinations, doing a variety of other reservoirs like studies looking into some of those viral decay and everything, which had good and bad responses, but still they have been improving these therapeutic vaccines by introducing several monoclonal antibodies and as well as broadly neutralizing antibodies in combinations with antiretroviral drugs. This is a work in progress. There are a lot of good studies being shown that proof of concept should work. Not just one antibody, but multiple antibodies we call BNAPs. If you give 2 or 3 along with antiretroviral drugs, probably we'll be able to suppress this virus, might even possible in future to get rid of this. This is a work in progress, but at this time, we don't have a good answer on therapeutic vaccines.
Dr. Dilakar, there's a question for you. What do a patient do if the patient is on Tafik and get tuberculosis?
When the patient is on?
Tafik, Bictegravir, TAF and FTC.
Actually, I think for tuberculosis, we have to...
The infection... Dr. Dinakar, not Divakar.
Okay.
Yeah,
Yeah.
well, there is clear data as far as dolutegravir is concerned. If you are using a rifamycin-based treatment, we need to double the dose of dolutegravir. If you think that is going to make therapy expensive, we can give a rifabutin-based regimen, and while preserving the integrase inhibitors. So that's about it. Otherwise, really no changes as far as treatment or any major drug interactions are not known to occur if you do this without losing the efficacy of the baseline ART, which is on.
I will continue question here. If the patient is on dolutegravir and gets a severe gastritis, what do you do?
Well, when gastritis is a very, what shall I say, non-specific symptom. So we need to be sure it's gastritis. It could be H. pylori infection. It could be pancreatitis mimicking gastritis. It could be even cholecystitis, which looks like gastritis. So if it is an acute gastritis, again, no major changes, but we need to remember that liquid antacids can reduce the levels of integrase inhibitors. So if you are giving liquid antacids, magnesium containing or any of the usual ones, you have to space it off at least for about 12 hours between the dolutegravir and other liquid antacids if you are using. So that's about the precaution. But if it's a gastritis doesn't respond to usual symptomatic treatment, then obviously we need to make sure that there is no H. pylori which may be present in these cases, or is it a mimicker of pancreatitis or cholecystitis?
There's a question on whether dropout from heart is more from the government sector or the private sector. I think Dr. Saple worked in government and private both. So whether the dropout is more from the government sector ART or private sector.
Talking about a comorbidity, no?
Dropouts from heart.
No, I could not get the question.
Treatment dropouts or people who are dropping out from heart treatment.
Yeah, it's a very good question. Of course, when you talk about the private, the care is better. People are more interested in taking, but those people who go to the government or general hospital, number one, their care is not as much as in the private. Number two, financially they are not doing so well. So they have to earn for themselves for their survival more than going, because I remember one of my patients who is a sweeper, but she is following with me for last 25 years. And last 25 years, she is taking regular medicine. She is on the first line of therapy. So I used to tell her, why don't you go to one of the government hospitals, because you can't afford. She said, no, I can't afford to go and stand in the queue, spend my day, who will look after my house? But now the cost of this therapy is only 900. So why I should go? I can afford to spend 900. So, these are the example, but definitely the government, the type of patient, type of the care, type of the time spent, counseling is a problem compared to the private. So definitely dropout is more in the public sector than the private sector.
Dr. Gilada.
No, one minute. It started happening after you left government, or it is same earlier or now, Dr. Saple?
Pardon?
It started happening more after you left government, or it is...
No, of course, initially the cost was very high. That one of my patients, I started on 20th of July, 96 on triple drug. The cost was 1 lakh rupees. How many patients could have afford?
Dr. Gilad, I will would like to differ what Dr. Sapre sir said. See, there are two things. One is the affordability as well as the time, what he was talking of. It is not for everybody. Most of the patients would like to go to government setup if they are not financially well. And definitely the same patient goes to a private sector, the dropout because of the financial economic reasons will be definitely less, definitely more, which I have already published my article on this, where I have compared both the things. And that if you see the dropout rate in government sector, it is definitely less as compared to those who is in private sector. In private sector, there are good doctors who are providing all the cares. But you tell me how many of the HIV practitioners, apart from HIV practitioners, those who are practicing HIV are giving a proper HIV medicine. So there is something good in a private sector and something bad in the private sector. Similarly, the things are there that there is sometimes there is a shortage and everything. But if overall you see the it totally depends upon a patient and the dropout rate. If the economics is not a main issue, then definitely it will be less in the private sector. But the economics is the main issue. Then I think they should go to the private sector, the government sector.
I think there was a study from their own NACO study where they were losing in 2 years follow-up 10% patient
23.2.
by death and 20% patient by
Yeah,
loss to follow-up.
yeah.
However, they started a mission called Mission Sampark, by which they could reconnect 7.5% patient back to ART center. That is one reason. Secondly, after the dolutegravir base or newer treatment have come, then we realized that some of our patients who were dropping out were also because of the efavirenz side effect, and we used to tell them that there is no other option but to take either nevirapine or efavirenz. Now there are other options, so we know that the same thing could be applied in the government sector, where they were having a efavirenz based regimen, people were dropping out. But now they are launching TLD based regimen. Actually, medicines have come only because of this lockdown. They have not been able to operate on those TLD based regimen. So with I probably will TLD based regimen, it will be better. There's one linked question with that. Does the place or literacy matters in role of adherence? Whether illiterate people are more adherent, less adherent, or whether the city or village, does it matter?
Can I answer this question?
No, no. Question is,
May,
if the
may
person
I
is,
answer?
yeah, you answer. Go ahead.
Yeah.
Short, short.
I'll just make it very short. If you ask me, it definitely depends upon the literacy, but it more depends on the counseling part. So the counselor is the main person who is going to see for the adherence rather than a literate or illiterate person. In my experience, the person who are coming from the rural area to my clinics and they are giving a proper counseling, they adhere more rather than a person who is literate and having n number of questions and Googles questions with him uh, and not adhering to the treatment. So I would definitely say that counseling plays a major part, whether it's a private or public sector.
There's a question, but I think it is answered in the talks, which is what factors contribute to the long-term survival? Any recent updates? That has already been covered in the talk. There's the next question. What do you think? NACO already damaged most of the kidneys and bones in all government PLHIV. I think we should not encourage such kind of questions. Is HCQ going to help PLHIV along with ART? HCQ. So repurposing that drug from COVID to non-COVID now. Kumar?
In the context of HIV or in the context of COVID?
HIV. The person is talking only HIV. Is HCQ is going to help our HIV patients or PLHIV patients along with ART?
Yeah, but now when we have wonderful ART, where do you want to mess up other drugs which we do not know anything on that? Only Trump knows how it works. So I think in the context of HIV, now we have got a very good antiretroviral drugs. I won't give any other thing. I will focus on them, make sure that they're virologically suppressed with that and adhere to them, and make sure that they don't have the side effects.
Next is for you only, Kumar. Role of ART, COVID and safety.
Role of ART?
ART in COVID patients.
Okay. I didn't have much time to talk about interactions between COVID drugs and HIV drugs. Now the only drug which is being now certified approved for use for emergency use in COVID is remdesivir. Again, has got no interactions with most of the HIV drugs. It has already been studied with the protease inhibitors, and we don't have any data with integrase inhibitor. I'm sure now will come up from New York, where they have put already on patients who are on bictegravir with remdesivir. They have already been shown. It's not been published and they have been documented and been said as part of webinars that there is no major interactions. But on the other hand, when you use some of those drugs like hydroxychloroquine, when you give with some of those antiretroviral drugs, particularly with protease inhibitors, it can be more harmful, because hydroxychloroquine itself can reduce arrhythmias, and when it's been given combined along with some of the HIV drugs like artesunavir and other protease inhibitors, it can produce more cardiac complications. So again, we don't have any definite therapy for COVID at this time, so we may not be able to know what are those particular interactions with specific anti-HIV drugs.
Kumar, question is not what you are answering. Question is role of ART in COVID, whether lopinavir, ritonavir, or any other ART can be used in COVID.
Okay, I'm sorry. Probably now it is 10:15. I'm being hypoglycemic. So now again, there is one paper shown from China stating that lopinavir helps patients. But again, soon another group from China did a randomized clinical trial comparing lopinavir versus their standard of care. They showed there's no benefit of lopinavir alone to SARS-CoV virus, either in terms of disease progression or to reducing the SARS-CoV virus in terms of the viral clearance within 7 days. So that study very clearly shows that lopinavir has got no major effect. But also, there are groups have shown, have studied in the laboratory whether darunavir has any effect. And I think it came from the industry, shown that darunavir have no effect on SARS-CoV-2 and is not being recommended. Also, there is a small study on tenofovir showed it may not have any much effect. Again, tenofovir can be similar like remdesivir, but a little different in terms of action. But again, need to be studied, because why people with HIV, when they're on predominantly on tenofovir-containing therapy, not acquiring a COVID, so probably they need to be studied whether it's got any prophylactic effect. Hopefully, there are groups have already been working on that. What about other integrase inhibitors? At this time, we do not know. That's what I think we all can develop this ecological data from our own cohorts on studying these patients and who have been HIV positive and doing testing on them on for COVID. And if they don't do that, then probably this is something proof of concept that whether these drugs will have any, at least a prophylactic effect. At this time, we don't have any data to show that whether that's how the drugs to treat COVID, but whether it will have any prophylactic effect, that need to be studied.
Dr. Luc Montagnier says that antigenicity, antigenically both HIV and COVID have similarities, which may be protecting them who are on ART from COVID. What do you say?
That's what I said about this defective cellular immunity in HIV. Probably that could be one of those protective effects. And again, it's too early to say. So because we have got less case reports on HIV and COVID. So that's one thing which I personally speculate that why people with HIV are not acquiring COVID.
Dr. Dinakar.
Yeah.
The question is, what should be the optimum strategy for managing metabolic complications of HIV and its medications?
Well, first, as I emphasized, we need to screen these patients, and it's not very difficult, and we know the basic criteria. I will not go into that. So having done that, we have to address the risk factors or other determinants, like, for example, poor lifestyle, lack of exercise, smoking, alcohol, etc. That has to be emphasized at every visit, which will obviously accelerate this metabolic syndrome process. So having done that and emphasized at every visit, we have to see the other risk factors for the Framingham risk score, etc. can be used. Basically, if anybody has a risk of major adverse cardiovascular events, what we call as MACE, more than 10% in the next 10 years, as per that equation, then these people should definitely be put on statins. Whether they should also be put on antiplatelet therapy, there's no studies available, but even primary prevention with statins is also still an ongoing thing. But if there are comorbidities, certainly they should be on statins, but be mindful of the drug-drug interactions. We should not use simvastatin, as I already mentioned, if patient is on protease inhibitors. So that is one aspect. As far as diabetic medications are concerned, there is no great interaction with the ART, but we also have to be aware that people on protease inhibitors, and if they are put on the DPP4 class of inhibitors, they can theoretically be a risk for pancreatitis, because both of them can induce pancreatitis. Otherwise, really no interactions as far as the newer GLP-1 receptor agonists or insulins or SGLT2 inhibitors are concerned. As far as antihypertensives are concerned, again, small drug interactions, not very clinically important, but I believe some studies have shown beta blockers with protease inhibitors can prolong QT interval, but again, we just need to monitor on a case-to-case basis. So weight gain issues with dolutegravir, again, as Dr. Kumar emphasized, we have to again balance it off with the other drivers of the metabolic syndrome. So that's about it. I think basically uh, uh, good control of diabetes, hypertension, prevent other modifiable risk factors like smoking, alcohol, lifestyle, and add statins in selective group of patients, particularly if the risk equation shows high risk for, more than 10% risk for cardiovascular events in the next 10 years.
Kumar, this question is for you. Dolutegravir is there in market for 6 months. You use dolutegravir and bictegravir both. Do you have to wait for some more time, or you can tell which one is better than other?
Both are same. Studies have shown both are equally efficacious, both the dolutegravir and bictegravir, and both have shown there is a weight gain. Developed world have used a lot on bictegravir where they have shown weight gain, and the developing country have used dolutegravir a lot where we have shown weight gain. So it's more of in terms of efficacy, it's nothing like that. Only thing, there's some advantages for dolutegravir is it can be given in TB patients where you can double the dose and give. It can be given in pregnancy. So right now, bictegravir cannot be given with rifampicin in TB patients, as well as we don't have any data on pregnancy. So I think we need to choose this depending upon which type of population we are going to use it. But to me, both are same in terms of efficacy. If someone who don't have a TB, someone who is not pregnant, for me that's fine. Whatever is been available and affordable to a patient, I will use it.
Just a comment. Sensitivity of RT-PCR for COVID-19 is 60 to 70% only.
We do not know. This is something nobody have done a randomized trial comparing different tests because we don't have much tests available. So the one that is currently available is used by RT-PCR. Also now we have Gene Expert, but all the principle is the same. So now we have a different technology come, then probably they'll be able to say what really the sensitivity. Right now I think there are people speculate. I said in my talk 75%, and CDC says anything around 80 to 90%. I think I will put anything from 75 to 90%.
Dr. Dinakar, what is the alternative to tenofovir in CKD patient with diabetes mellitus?
Yeah, it's a good question because as a knee-jerk reaction, all of us have been shifting our patients from TAF to TDF. But if there is already a pre-existing diabetic-related kidney disease, which can very easily be assessed by looking at this kidney size or a protein creatinine ratio in the urine or the creatinine and EGFR, it is better to avoid the tenofovir and TAF as a whole, because although TAF does not have any direct renal toxicity, since we have other alternatives which have absolutely no effect on the renal function, we can definitely, TDF should not be used. TAF can be used with caution as long as you are monitoring, but if patient has already overt kidney disease due to diabetes, or for that matter, if there's a coexisting hypertension, etc., then we can avoid that nucleotide group of drugs and use drugs like integrase inhibitors, which have practically no effect on the renal system.
Dr. Bhushundi, there's a question for you. We have used atazanavir, ritonavir in our setting a lot. What is your experience about related to neurocognitive disorders associated with this? And in such scenario, what's the substitution strategy? Unmute.
Yeah, a very nice question. We have used atazanavir, ritonavir in many patients, but what I'm talking about the CNS escape was usually seen with with a not so nice CP score. So we had one series in Nagpur as well as in Pune from Dr. Dravir, where we have seen that when atazanavir, ritonavir was replaced by after doing definitely the viral load with the undetectable and the CSF viral load is detectable, and we switch over to dolutegravir with a good CP score. Definitely there was a change, and these patients have responded very well. with total reversal or partial reversal of the neurological symptoms.
There's a question about any
Dr.
HIV patient.
Gilada, Dr. Gilada, I would like to add here. Can I add?
Okay.
Yeah, see, atazanavir is not a good drug for the CNS penetration. So in fact, any patient comes to the HIV clinicians with a neurological manifestation without any fever, only neurological manifestation. If I ask history, patient is on atazanavir for last 3-4 years or 5-6 years, with the CD4 count is good, plasma viral load is undetectable, you can suspect is a HIV encephalopathy because atazanavir is not a good. So any patient with atazanavir for more than 5-6 years, always there are chances of HIV encephalopathy.
Very good, Dr. Sam. Now there's a question, any HIV patient with COVID positive results, which are asymptomatic. I think there are not many patients with COVID and HIV. We are trying to make a registry for HIV COVID through ASI. Dr. Kumar Swamy is going to share a form for this kind of registry with all of you. So if you come across any COVID patient in HIV patient on ART or without ART, we must register there. There is a question. I work for government ART center. Guide me. How can I work for private practice? Who will answer? I think that is individualistic. We cannot. There are some people in Karnataka who are doing ART center work and private practice both uh, here and there. So, as a programmatic concern in national program, would the panelists like to vote for TLF, TDF plus 3TC plus DTG or TAP plus FTC plus DTG? Or better to give an option for clinician to opt for either of the regimens depending on renal toxicity versus obesity to the patients in national program. I think in national program there is only TLD. There is nothing, no option of TED. So emtricitabine is not there in the combination in the national program. It's a TLD program. Cytokine storm happens both in HIV and COVID. I think Kumar has already covered that. Dr. Matin has asked this question. Cytokine storm happens both in HIV and COVID. So should there be a synergistic cytokine storm, a HIV patient comorbid with COVID-19 phase, synergistic MA?
Yeah. So actually, when they document the pathogenesis of COVID disease, stating that cytokine storm is the one which is causing the disease progression. So we all send advisories to various guidelines stating that all our HIV infected people should be protected, and probably HIV will be one of those comorbidities which can cause disease progressions in SARS-CoV. So even in fact, we spoke about this in different media, but his good thing is that we don't see much COVID in HIV infected people. So the question is very relevant. I showed in that cartoon, when someone who is HIV positive, within a couple of days, they'll have a cytokine storm. Most of the cytokine, pro-inflammatory cytokine, interleukin-6, TNF-alpha, IP-10, everything is upregulated. And because of that, patients develop this acute infection or seroconversion illness, like typical like influenza-like illness, like ILI, which has been developed because of the cytokine storm, which has happened in HIV as acute infection. And because of the host immune response, when the virus goes down, that cytokine little goes down on its own. So that's what patients feel better. So now in the context of SARS-CoV, whether this will cause more fire on that, we do not know. Since we are not seeing much COVID in the context of HIV, we are not able to study this, but we have to be very careful with our patients when they acquire COVID and HIV, whether it could be one of those possibilities.
There's a question for Dr. Devakar Tejaswi now.
Dr. Gilada, can I add for that?
1 minute.
About the cytokine storm?
Just a minute. Yeah, go ahead.
Yeah, we are talking about cytokine storm. In HIV, usually it occurs during primary HIV infection. Once it becomes a chronic, the cytokine release is not that storm. There is a cytokine release because of the inflammation. but cytokine storm occurs in HIV, in the primary HIV. And how many primary HIV you are going to have with the COVID?
Okay. Dr. Devakar Tejaswi, there's a question for you. Is there any role of spiritual healing as aging is inevitable?
Actually, we have seen that if there is calm mind, yoga, and other things which keeps you calm, that is definitely going to help. But there, I cannot say that the spiritual healing can be of directly any evidence based in the treatment or in the management of these things. But definitely, if you are having a disciplined life, 6-7 hours of sleep, good concentration, good meditation, good yoga, good active life, good disciplined life regarding your eating habit, your exercises, definitely it is going to heal. And this is meditation, this is yogic, and this is you can see spiritual healing.
There's one question. Can you use TAF in patient who has developed AKI on TDF-based regimen? Dinakar, Dr. Dinakar.
Yeah, see, when you are dealing with AKI, even after that so-called biochemical recovery, there is always a residual amount of renal damage left. And there are several studies, not just related to HIV alone, but all AKI, if you take, a creatine may have biochemically recovered, but there is always going to be some amount of residual glomerular loss or a nephron loss. So in that situation, when you have now wide choices of nephro-friendly drugs, ART classes of drugs, for example, in INSTI, so there is no need to again unnecessarily go back to the similar class. Although we know that TAF is used at a much lower dose and it hardly has any renal toxicity because you know the pathway it's taken up directly by the lymphocytes. So in the patient who is clearly diagnosed as AKI, as I mentioned, creatine is used because it's very easy to do, easily reproducible, cheap test. But that doesn't reflect the entire story of the kidney injury. So in that situation, if you're going to use only creatine as your marker for monitoring nephrotoxicity, you may be missing it. And you may actually have produced a nephrotoxicity or started using drugs when the kidney is not completely recovered. Because your recovery, what we are measuring on a day-to-day clinical basis, is purely on the surrogate marker of serum creatine, which has its own limitation. So better to avoid drugs like TDF, TAF, and use drugs which have absolutely no effect on the renal system.
Good. Dr. Tejaswi, can we postpone aging by if inflammation by IL-6 storm, etc., or can it be controlled by HCQS, aspirin, ibuprofen? Your comment.
Actually, this IL-6 storm, cytokine storm, this which we are getting in HIV is low-grade inflammatory processes. It is not cytokine storm at that time when there is ongoing replication of virus, as Dr. Saple has already mentioned. It is only in the acute phase we are getting this type of immune reactions like IL-6 and cytokine. So at present, if there is no comorbidity of rheumatoid arthritis and other things, I think this type of immunomodulator like HCQS and other things won't be helpful in HIV patient to reduce the inflammation. But at the same time, your sleep, which is immune modulator itself, 7 hours of sound sleep, your disciplined life, your exercises, this, and your diet, which is not deficient in vitamin D3, you have to take vitamin D3 and zinc and other things. It will be definitely boost your immune system, and no need to take this anti-inflammatory medication.
The last but one question: what is your take on bictegravir-based regimen on treatment-naive patients? I think anybody can take, everybody can take. Dr. Dinakar, bictegravir-based regimen.
Yeah, I think now the guidelines are clear. We are moving away from efavirenz-based. Dr. Kumaraswamy killed it in the last WHO guidelines. I think they were all of us were keen to kill the NNRTA. So now it's very clear between BICT and Dolu, really nothing much to choose. And so they will come in a very big way. Integrase inhibitors will be used as first line, second line, third line. So you will see it across the board, and there is no much discussion. and already it is available in our country as a single pill regimen. So it is there to stay. It will be the drug of choice if depending on the availability in various sectors.
Dr. Sapre?
Yeah, as per this, Bictegravir is, can you repeat the question? Sorry.
Role of
Yeah,
bictegravir in naive
yeah,
patients.
yeah, there are many more trials. Bictegravir can be used as a naive patient. In fact, if you see the guidelines of DHS, guideline of the European Society of HIV/AIDS, they say the Bictegravir is the first drug of choice, is the first preferred drugs as compared to other drugs. Of course, dolutegravir can be used, and darunavir can be in PI. Darunavir can be used. So this can be used as a first line of therapy. But when you're using any drug in your individual patient, it has to be individualization. The first, the drug has to be effective. Secondly, it has to be safe. Thirdly, it has to be cost effective. Fourthly, drug-drug interaction. There are many more factors. So while selecting drugs is an individualization, and in a given condition, you have to select more than just guideline. Guideline is there to help you, but that is not the last answer. Ultimately, you have to take your own call.
One question has come for me. It says now we are talking about metabolic disease as patients are living long due to wonderful and convenient FDC available due to you do you feel this issues related to extraordinary weight gain related to INSTI will be not an impact and outcome in future morbidity associated with such patients? Your comments. I think weight gain we see is mostly in the first year, and that too it is if you are using FTC is a 6 kg plus 3 kg minus, so balancing. And if we ask people to take precautions since beginning, do exercises, do yoga, do walks, I think it stables down. But we are yet to see untoward side effects or very big side effects because we have not used integrase inhibitor for longer period. So I think we have to wait and watch in those kind of situation. And yes,
I think it is a good observation what you said. So, the weight averages. But what's been particularly seen in South African, that advanced studies, in Black African women, the weight gain was so huge, as well as similar things were seen in Afro-American, individuals. So that means this weight gain is caused not just with the drug alone, something, a combination factors. We also feel that it could be something genetic predisposed. So a certain population might prone to pick up more weight with this. This need to be studied. So at this time, with the available data, I think we should not throw away any of those integrase inhibitors out and bring back these old NNRTI, because integrase is such a wonderful drugs, suppress the virus so quickly. It not only prevents HIV-related complications quickly, but also prevents sexual transmission of HIV, because it dips the virus so quickly, thereby it reduces transmission. I think the right time that I think we should be a big advocate of moving this forward everywhere. Still our national program has not introduced. I think we should be an advocate towards it. And also to the question on bictegravir, when this should be used, I think these are the wonderful drugs. We should use as a first line. Never preserve these drugs at the end. We should use as a friend and make sure that they take these drugs, less toxic drugs, for a prolonged period of time, but without any virological failure.
last question has come. Is dolutegravir available in national program? Yes, it is available. They have procured dolutegravir. What they are doing is they are first shifting all raltegravir based patient to dolutegravir. Then newer starting, they are all doing on TLD, and then after that they will switch patient which are on efavirenz based regimen to TLD. So procurement is done in big way. They have not yet started, but some of our private patients who were stuck somewhere in between the NACO program or NACO ART centers, they have provided TLD based regimen to our patients which are stuck without being registered with the ART center. So thanks to NACO, they have done that. At the end, I think this is one of the longest webinars we had. It's going on for 2 hours 45 minutes. We would like to thank all the panelists. They have done wonderful job. The topics were very difficult. It's not so easy topic as we see in conferences. So firstly, thank the Hitro Pharma, Hitro Healthcare for choosing this particular day and such a difficult topic, and then subdividing into 10 different subtopics. We have wonderfully covered everything. I think if something comes out of this kind of document or paper or some clip, I think that will be very much useful.